Okay, let's do it. Okay, welcome everybody to day 3 of this week of our hearings for the Health Committee. I want to start by acknowledging that we're all gathered today on the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh people, and we have some members on the phone, so I'll just invite them to reflect the territory that they're on, and that we guide our work and think about that as we proceed. This morning we have Jasmine Bradley, Executive Director of Communications and Public Affairs at ECOM 911. I just want to welcome you on behalf of the committee. We're looking forward to learning from you. You have about 20 minutes, and then we'll have 40 minutes of questions and answers after that. Okay, over to you.
Thank you very much. And thank you for the opportunity to present to the Select Standing Committee on Health as you examine the urgent and ongoing illicit drug toxicity and overdose crisis. On behalf of ECOM 911, I'm pleased to be here and look forward to our time together. I'll briefly offer some background first on our organization, how the system currently works and deals with emergency calls, including overdoses, and provide some insight into opportunities that ECOM believes will strongly help to improve the service moving forward into the future. But let me begin with some background information on ECOM. Municipalities and public safety agencies in the Lower Mainland established ECOM in 1997 under the Provincial Emergency Communications Corporations Act. It was formed in response to the 1994 Stanley Cup riots in Vancouver, when police, fire, and ambulance first responders were unable to communicate as a result of incompatible radio systems. How appropriate, a hockey game, very Canadian story and start to ECOM. Initially, after being formed, we had 3 primary lines of business: operating an integrated regional radio system used by police, fire, and ambulance agencies throughout the Lower Mainland, and providing dispatch center services for several Lower Mainland police and fire departments, as well as answering 911 calls, originally just for the Metro Vancouver Regional District. Since 1994, ECOM has grown significantly, and we're now the first point of contact for 911 callers for 99% of 911 callers in British Columbia. If you dial 911 in the areas that we serve, your call will first come to an ECOM 911 call taker, and we will triage those calls to the requested police, fire, or ambulance agency that's asked for. Out of the 911 calls that we answer, 65% are to police, 5% are to fire, and 30% are to ambulance. I think it's important to emphasize at this point that in terms of dispatch services, ECOM doesn't dispatch for the BC Ambulance Service. That's done by BC Emergency Health Services. Therefore, we don't have a significant role and or impact on how these calls in particular are handled. When a caller dials 911, we'll ask if they need police, fire, and ambulance, and in the case of overdose calls, these will likely go to BC Emergency Health Services, at which point we disconnect from the call and go on to answer other incoming emergency calls. In particular, while we maintain detailed data of our overall call volumes and response times, we don't track the type of health emergency for calls that are transferred to BCEHS, such as, for example, overdose calls. Instead, data on overdose calls is maintained by BCEHS, and we understand that this committee will be hearing from their organization, so we'll allow them to provide specific data on overdose calls specifically. Given that, what I can speak to is the overall increase in demand and strain on emergency services in general, in terms of those initial 911 calls that are coming through our centre, which does include overdose calls. We know from BCEHS's public reporting that the opioid crisis is significantly adding to their 911 call volumes. And indeed, it's just one of many factors that we're facing at ECOM that are significantly increasing our overall call volumes and impacting the service. I'm sure all of you have heard in the news the challenges with BC's 911 system over the past year, and I'd like to take some time to explain some of those challenges and then offer insight into how we can improve this system and offer British Columbians the level of service that they deserve. ECOM provides 911 services. We answer 99% of 911 calls in BC, and that breaks down to us providing service to 25 out of the 27 regional districts in the province. but nearly a quarter of the province's land does not have 911 service. This includes the Stikine region, much of the North Coast Regional District outside of Prince Rupert, including Haudenosaunee, the entire Central Coast Regional District, including Bella Coola, parts of the Northern Rockies Regional Municipality, and parts of the otherwise served regional districts, particularly Indigenous communities. This means that if someone is overdosing in these unserviced regions, they have no access to emergency services. In addition, even where 911 is available, the lack of cellular coverage in many parts of BC due to our geography continues to limit access to 911 services. Further, it is our opinion the lack of consistent province-wide standards for 911 in BC increases the risk of service disparities. The governance structure is based on ECOM's original Lower Mainland radio system shareholders and is not reflective of our subsequent expanded provincial footprint. For example, nearly all of ECOM's municipal and public safety agency shareholders and board of directors are based in the Lower Mainland, despite the fact our organization serves the broader province. We work with more than 100 different public safety organizations and agencies, each with varying needs, resources, and requirements. Finding agreement can be challenging and has resulted in differing processes, procedures, and service level agreements between regional districts and individual police and fire departments. This makes it very resource intense and slow to evolve 911 emergency communications in BC and is a major roadblock to improvements in the face of all challenges. A further challenge facing the system is the fact that BC's 911 emergency communication system is more than 30 years old and increasingly at risk of failure. Calls to 911 are directed through special infrastructure dedicated to emergency communications and are not part of the regular telephony network. Because this infrastructure has not been updated anywhere in Canada, it has, in particular, not yet been migrated over to the new Internet Protocol or digital system in terms of the infrastructure itself. These infrastructure improvements will be addressed as part of a project that is called Next Generation 911, and I'll go into detail in a moment on that project. But the change management for this is challenging and it's costly to implement and operate. Finally, in terms of pressure on the system, 911 call volumes have been significantly increasing over the past few years, placing added pressure on call takers and first responders alike. This has been compounded in BC by a growing population, climate-related events, 3 states of emergency, the ongoing COVID-19 global pandemic, and, of course, the opioid crisis, along with other complex mental health and social issues. Last summer, during the June 2021 heat dome and subsequent wildfires and flooding, the combination of these forces resulted in emergency services being strained to the breaking point. The busiest days in ECOM's 23 years of service occurred last year, at one point dropping to 81% of 911 calls being answered in 5 seconds or less. This is well below ECOM's nationally leading service standard of answering 95% of 911 calls within 5 seconds or less, although call response subsequently did improve to 91% by the end of 2021. As elsewhere, the rise of cell phones has contributed to higher call volumes in BC, as has significant population growth. Metro Vancouver alone is planning for a further 1 million new residents by 2050. As a result, call volumes will increase. In the last quarter of 2021 alone, call volumes were 22% higher compared to the year prior, and we are projecting a further increase of 13% in 2022. In fact, heading into what traditionally is always the busiest time of year for ECOM and emergency services, we're very concerned about the number of emergency calls we might see this summer as our province moves towards a summer where COVID restrictions are no longer in place. Major gatherings can happen. The potential for other extreme weather events as well. Simply put, demand and strain on the emergency services system has turned the extraordinary into the ordinary. And the challenges that we face and the need to strengthen the system, these are not going away. As we move forward and consider how ECOM can work with other service providers, first responders in particular, there is an opportunity to improve the system. There is a little bit of light at the end of the tunnel. And this is Next Generation 911. This is a federally mandated modernization of 911 networks and infrastructure across Canada. This will essentially allow our systems to adapt to new and emerging voice technology and messaging services by moving to a digital platform. For example, with 88% of BC households having at least one cell phone and 80% of 911 calls coming via cell phone, texting options will make 911 even more accessible. NG 911 will significantly enhance 911 service in Canada by changing to IP-based networks that support modern new features while ensuring this life-saving system remains effective, secure, and resilient. This shift will enhance accessibility by allowing greater access to the deaf, deafblind, hard of hearing, and speech-impaired community, enabling people to text directly to 911. It also has the potential to expand and enhance the level of service provided to people in mental health crisis by more directly connecting community-based resources into the 911 system itself. This change will also help Indigenous communities and rural BC communities across access the service the same way those in urban areas do already. This is a critically important shift that will ultimately help more British Columbians. The CRTC has set a 2024 deadline to deliver NG 911 services across Canada. And to ensure a smooth and effective transition to NG 911 here in BC, ECOM believes there are two key actions required. One, the province needs to establish a provincial level 911 authority and funding model for policy and standards of service. Number two, we need to elevate police dispatch authority from the municipal to the provincial level, which will support a single, integrated provincial police call-taking and dispatch service. These proposed changes are significant, but are also needed to ensure a smooth transition to a better, more equitable, and accessible service that will meet the needs of British Columbians and hopefully help save more lives that are unnecessarily lost to the opioid crisis every day. NG 911 will also evolve existing emergency services in ways that can and will help the toxic drug supply and opioid crisis, such as more precise information on location for callers, information that's essential for effective and swift emergency response. The option to text 911 in addition to calling and sending images and video to 911 from the ground. Direct incident information transfer to first responders on the road so they are better prepared upon arrival for an overdose situation. Health condition-specific responses for complex social issues like mental health and addiction that removes the stigma of 911 for some vulnerable populations. New ways to triage and direct calls to services other than police, fire, and ambulance. Right now, those are our three options. With Next Generation 911, it does provide the opportunity to look at a possible fourth option for more community-based supports. Call transfer capabilities across the province and country is also going to be possible with Next Generation 911. I'm sure some of you have heard in the news of recent 911 network disruptions. With Next Generation 911, were that to happen, we would have more capabilities to ask other dispatch centers, potentially Calgary 911 as one example, to take incoming 911 calls for BC while that disruption occurs. Different alerts based on incident that can trigger alternative responses for different situations, and culturally safe emergency service options, such as for Indigenous communities and other racialized and marginalized people. These are just some examples of the benefits of NG 911 that will improve how emergency service responds to opioid overdose and mental health and addiction-related calls to better address these types of incidents. So what is the path forward? We believe for BC to fully embrace the opportunity NG 911 presents, it needs a provincial mandate. 8 provinces in Canada now have some form of provincial legislation governing 911 service delivery and standards. BC and Ontario are the only 2 that do not. In the past few months, Newfoundland and Labrador became the latest provinces to move to bring responsibility for 911 service delivery under the provincial government, while Ontario announced significant new provincial investments of $208 million in 911 emergency response, including to help implement NG 911. From a standardization perspective, we believe calls such as those related to an overdose need a consistent approach and response. But currently the system is fragmented across BC. And if not remedied, this gap and divide between different communities across the province will only continue to grow. For example, we have separate health authorities, separate police departments, and in some regions, separate emergency communication centers that may all have different ways of responding to an overdose call. ECOM believes a new way of responding, one that is consistent and standardized, is key moving forward. It is our view that this would include the consolidation of 911 and police call taking and dispatch. For example, if you look at the two largest centers for opioid overdoses, Vancouver and Surrey, they illustrate the challenges I was just speaking to about the fragmented system in BC. For what is an invisible line for a person overdosing in these two cities, the response is quite different because we have two different police structures, RCMP and municipal, two different dispatch centers, and two different sets of standards and protocols around 911 call response. So even within Metro Vancouver and the examples I just provided of Vancouver and Surrey, we have inconsistencies that really should not exist. In closing, the demands on 911 in BC are growing. The deadlines for NG 911 improvements are quickly approaching, and we continue to see far too many deaths as a result of the toxic drug supply and the opioid crisis. I commend this committee for taking on this important work, and as you work toward identifying possible solutions from every aspect of the crisis, ECOM is committed to working with you and doing all we can to support your efforts. Our team cares deeply for the people we help every day, and we are eager to be part of the solution moving forward. ECOM is grateful for the support and leadership of this important priority by all parties of the Legislature. I'm now happy to take any questions.
Thank you so much, Jasmine. All right, committee members, any questions for Jasmine? Go ahead, Pam. Sonia and Dan. Okay.
You talked about growth. So is the new system, Next Generation 911, have the ability to take on more clients? Because obviously we're growing at a very rapid pace. And so is there that capacity, and what is the plan for population growth as far as ECOM goes?
The increased capacity with Next Gen 911 is significant, and I think what's most important about that potential with the growth is the ability to be able to extend that service across areas of the province that currently don't have access to 911. Because it is moving to a digital system, that ability to be able to expand the service into those areas is greatly enhanced, and that's where we see the biggest opportunity in terms of that growth piece.
So that's one kind of growth. Sorry, follow up if I could. But certainly we're looking at Surrey with, I don't know, over 1,000 people a month moving in. So is that system just in those two centers that you spoke of initially, is it able to handle additional call volume? And what are your plans for that additional call volume? Are you looking at increasing your staff? Like, tell me about that.
It's a great question, and from a technical perspective, NG 911 will offer that increased capacity for growth that is going to be required. It doesn't take away from the challenges that we are already having in terms of staffing, in terms of the people power behind that. What comes with that is the need for ECOM to really look at closely with our partners different ways of doing the work that we do. How can we leverage technology in new ways so that we're able to resource from a people perspective the call takers and dispatchers we need, but perhaps technology plays a greater role in that in terms of triaging some of the calls before they even get to a call taker. So for example, if I take the non-police non-emergency line service that we provide to our police partners, we estimate that about 4% of those calls coming through the non-emergency lines aren't actually police matters and need to be redirected. If we take technology and put it into that picture and can get rid of that 40%, that will reduce the call volume demand that is hitting our people. So looking at different ways, that's just one example, and is obviously not a 911 example, but looking at different ways we can automate more and triage calls differently. And it will never take away from the fact that we will need more people in order to meet the increasing demand. We don't have enough people now to meet the demand that we're seeing, let alone increasing demand over the years.
Okay, thank you so much.
Sonia, go ahead.
Oh, no, I didn't.
Oh, you didn't? I'm sorry. Go ahead, Dan. I thought your hand was up.
Thanks, Chair, and very, very informative. I got a few little points here. Hopefully I'll try and squish them in all at once. We brought this up. I sat on the other committee to reform the Police Act, and I know we had a couple of presentations by ECOM, and one of the big concerns, and I'll start with a bit of a preamble, and then I'll move to a couple of questions if I might, Chair. Of course, I represent one of those areas that has massive land that's not covered by by any 911, which is a big challenge, and and it's a fact of there's no cell phone service. Often there is no phone. There's no internet. So we have a lot of work to do, I think, before we even get to the point of expanding those services. My question, I guess, around this new next gen 911, it sounds like we're just kind of in the stages here in BC, anyways, of getting this organized. You talked a little bit about federal mandate and funding. What is that? My first question is, what does the funding look like? Do you need massive amounts of provincial money? Is this ECOM, because I believe ECOM is a private company that provides the service? Is this being done, and the fees will go up? Or what does that funding look like? Or how do you get I imagine it'll be quite expensive, so to get that money piece sorted out?
Yes, great question. So currently, ECOM's 911 call answer service is contracted to each of the 25 regional districts that we serve. Last year, the cost for that service across the board for our regional district partners was around the $7 million mark. But with Next Generation 911, this is going to go up significantly. In terms of tens of millions of dollars. It's going to be a significant cost. And it's our opinion that local government just simply does not have the ability to fund what we know is going to be a hefty price tag for this transition to next gen. And that's where our belief in a provincial mandate in terms of oversight, both for policy, for standardization purposes, but also funding. So right now, local government doesn't have the ability to leverage a wireless call answer levy in terms of funding 911 services. I mentioned we answered more than 2 million 911 calls last year. 80% of those came from cell phones. And so currently, local government has the ability to fund 911 services through property taxes and landline call answer levies. But the significant users of the system are not funding that. So if I take my home alone, between my work phone, my cell phone, my teenage kids' phones, my husband, there's 6 cell phones that are all capable of calling 911 and using the system, but that's not contributing towards the funding. So,
and I think there is and this is one of the things that I noticed, our regional district, went to ECOM, 8, 9, 10 years ago or something like that. And I know there was a lot of discussions and such. And I know this is one of the issues that I had with the system at the time is, a regional district paid for the service that they got, right? And that's why you got these different levels of service all across the province. You identified the challenge, municipalities coming from a municipal background, you're already talking tens of millions of dollars more. There is no way that the municipalities are going to be able to afford it. So I guess I'll just follow up quickly, and I have some others, but I'll let others go. Has there been some dialogue already with local governments, regional districts, to say that this is coming, and we're working on getting this moving forward? And if so, and I assume so, what have those discussions been like?
Yes, absolutely. ECOM executive and board have been actively engaging with our regional district and municipal partners in terms of our advocacy around a provincial mandate for 911, and there is a resounding support for moving in that direction. I want to reference the fact that this idea of provincial oversight in terms of 911, specifically through a call answer levy for wireless, it's something that's been brought forward numerous times. I know that you mentioned you were part of those discussions. It's been brought forward to UBCM as a resolution, and it's not passed. ECOM believes that now is the time that this should pass and will pass in terms of the support that's needed, specifically because Next Generation 911 is coming. It's federally mandated. This is not an option. It needs to happen in terms of moving to this new system, and the costs of that need to be covered. So we do have a UBCM resolution that will be put forward in September. Vancouver City Council has supported that, and we'll be moving that forward to the UBCM September convention, where we hope that this time around it will pass.
Okay, Rona, go ahead.
Thank you very much for your presentation. Appreciate it. I could see that we could go really broad here and start talking about 911 generally, but because we're talking about overdose deaths, I wanted to focus on a couple of things that you said that I'd just like you to respond to. In the old days, I was in local government, and I remember the decision-making process that we had to move to ECOM 911 because it was going to be more expensive to stay local. Yeah. And so going back to that is not going to work. Whatever. But in the place that we're concerned about now, and you've mentioned it, is the lack of that digital platform at homes for people to access the 911. So it's a kind of a chicken and egg question I have, that how can we go to a digital platform if it's not going to serve certain parts of the community until we're working hard to increase that capacity throughout the province. But how can we get there? I guess that's the chicken and egg question. And the second question, you mentioned about the capacity of it to provide culturally safe services, and I'm wondering why you can't do that now, or if you can, will be enhancing that service.
Yes, I think I understand your chicken and egg question, but let me know if I'm not answering it directly. So the move to an IP-based digital system for Next Generation 911, it can happen within our current service footprint, where the opportunity with Next Generation exists is when the province is in a position and able to expand services in those areas that currently don't have it. That system would be able to seamlessly move to provide 911 access in those areas, whereas with the current analog system, that is a lot more difficult and challenging. So when we roll out Next Generation 911, the two systems will exist simultaneously for a period of time, and then there will come a point where TELUS will shut off the current system, and then we will operate fully on the IP-based Next Generation system. It would just be in the same footprint of where the service is available today, but we would be able to expand upon that service and offer it to other communities once the province is ready and TELUS has built out that infrastructure to be able to allow that to happen. Does that answer the chicken and egg question?
Yeah. I have a little follow-up around the use of, you mentioned radio and landlines, and I'm wondering if that's is that the bridge piece? Like, how much can we rely on old technology, which is what helped build communities in remote areas in the first place, to bridge that divide?
Yeah, I mean, you brought up an interesting point about, relying on the old technology. The system in BC is more than 30 years old. The technology is aging. It's coming to its natural end of life. And the recent service disruptions in terms of the 911 network that have been covered in the media lately more of those situations are going to keep happening as the system continues to age. So that's where the reliance on the technology really does come into play in terms of needing to move to that enhanced system, that digital system, for the redundancy, for the capacity, whether that is stabilizing the system itself or expanding that to offer it to other areas of the province. In terms of the radio piece, it's slightly different in terms of it's not operating on the same network or infrastructure or technology as the actual 911 network itself. Currently, ECOM has our radio system exists in the Lower Main, Metro Vancouver, and through to parts of the Fraser Valley, but that's it. I'm not aware of any discussions that have been happening in terms of expanding that further, but it is definitely part of our strategic plan in terms of our belief in having that interoperability and that capability for police, fire, and ambulance, no matter where they are, to communicate seamlessly with each other. So, it could go hand in hand there, but they're not directly connected.
And then the culturally safe services.
Yes, so that ties into more of the options that Next Gen 911 as a system would offer in terms of how we treat 911 calls when they're coming in. So currently they come in and the only three options are you send it to police, you send it to fire, or you send it to ambulance. We know that, a vast majority of the mental health calls go to police. We know that the vast majority of the overdose calls go to ambulance. Not to say that the three tri-services aren't connected and responding together and supporting each other, but with Next Gen 911 and our ability to expand our model of response, it's looking at what could a fourth option be, so that maybe not all of the mental health calls need to go to police. Notwithstanding the importance of making sure that police are involved in response where warranted, but looking at different, more community-based options for the mental health calls, for potentially those overdose calls as well, and being able to offer that in a way that better supports the community. Another piece around the culturally sensitive expansion of services could be opportunities like having a 911 center established specifically for Indigenous communities that are staffed by Indigenous peoples as well, to offer more of that culturally sensitive response option for the people that are served in that area.
And that requires this digital Next Gen.
It makes that transition much easier to make happen. Absolutely.
Thanks.
Susie, go ahead.
Thanks very much, and thank you for your presentation. I appreciate it. Sort of two combined into one, I think. I'm hearing that right now, 25 areas, different ways of doing business. Does that include the training of the dispatch folks as well?
Yes, it does.
So each area is responsible for its own training, are they, or do they have a standardized training? They do not have a standardized training. Okay.
That's correct.
And so the other question around the culturally sensitive stuff is do you have language options?
We do have language options. We have a translation service that's available 24/7 in more than 173 different languages. And in situations requiring a translator to be on the line, it's like a three-way calling scenario between the caller, our call taker, and the translator.
Okay, very good. Thank you.
Mm-hmm.
Shirley.
Well, thank you for being here. I think we recognize that the job of dispatch is not easy. And I think all of us need to recognize that during the very difficult times we faced, particularly during the heat dome, I'm sure that for people working to dispatch calls, probably faced a lot of stress. I appreciate your presentation. I'm wondering if I just have a couple of questions in sequence. Can you just articulate for us specifically what parts of the province ECOM currently serves?
Absolutely. And first of all, thank you for your acknowledgement of the demand and strain that last year had on the call takers and dispatchers, ECOM and others. Unprecedented is the way to describe that impact. It's a demanding job on normal days. We still at ECOM have staff who are on long-term leave because of the stress of last year. In fact, excuse me, we currently have 34% less call takers than we did this time last year. partially due to the tight labor market and the challenges that we know that many other organizations, including public safety organizations, are experiencing right now in recruiting and retaining staff, but also because of the number of staff that we have on leave, which is of concern to our organization. For the services, for the regional districts that we currently provide services to, that includes I'm going by memory here, so Metro Vancouver, the regional districts within Metro Vancouver, our contract for the north is with Fraser Fort George. There's 4 regional districts in that area. Our contract for the interior is with the regional district of the Central Okanagan. We also have the Fraser Valley. Basically, the out of the areas in BC that have access to 911 services currently that don't fall under ECOM's service area, it's Prince Rupert that has its own system, and Nelson that has its own system as well. All other parts of British Columbia that have 911 service through TELUS fall under ECOM in terms of that provision of the service.
So expansion to a provincial system is not really overly substantive because most of the province is covered. Is that accurate?
There are some areas that, significant areas that do not. Let me just go back.
And while you're looking at that, so I'm thinking about in our circumstance, so I believe, for example, that Prince George Fire Rescue, they still have dispatch.
Yes.
How does that fit with what you're suggesting here?
So currently with the model for using Prince George as the example, ECOM will answer that initial part of the 911 call, and our call taker will say, 911, do you need police, fire, ambulance? We'll confirm their location. And then for callers in Prince George, we will transfer those calls, similar to how we handle requests for the ambulance service going to BCEHS, transfer those calls and disconnect once they've been accepted by a call taker.
So you're not suggesting displacing fire rescue dispatch, for example, in a community like Prince George?
No, ECOM's focus at this point is that we do see value, and this aligns with the recommendations from the Special Committee on Reforming the Police Act in terms of looking in the future to consolidating police emergency communications as well. Currently, ECOM does provide dispatch service, call taking and dispatch service for 33 police agencies across BC and 40 fire departments across BC. On the policing side, though, even using the Surrey and Vancouver overdose example that I was speaking to earlier, for Surrey, ECOM will answer the 911 call, but then we transfer it to Surrey RCMP, we transfer it to Surrey Fire and to BCEHS. For Vancouver, we will transfer that 911 call to one of our police call takers and one of our fire call takers because we dispatch for Vancouver Police and Fire.
But there's always a secondary call, whether it's to your dispatch or
Exactly.
Dispatch. So, I mean, I will just state my bias. I mean, I like having the local, it is not unheard of to have people call and people don't know where we live. Mm-hmm. Like if you live in Dome Creek, British Columbia, there are people who don't know where that is. I would rather have the hope that somebody who answers the phone actually knows what we're talking about. But I guess my last question, Chair, and thanks for your indulgence here. Not in a partisan way, but what happened during the heat dome was absolutely devastating in this province. Absolutely devastating. And we are now heading into floods. I mean, we have people today who are facing floods. We're probably going to face fire, and who knows whether we'll face another heat dome. There was significant concern about the capability of ECOM to respond at the time. We have 2 concurrent crises happening, basically, at that time. Has enough change been made today? So I think it's great we're talking about expansion. We need to make sure the base works before we start adding other expectations. And you say that there are 34% less call takers. So has enough change been made at ECOM and elsewhere? I know that dispatchers were beside themselves with stress and worry. So maybe you can just speak to, are we ready? And, I, for one, think we need to have the base, making sure it works effectively before we contemplate taking on additional work. But maybe you could just speak to that.
Yeah, and I'll start by answering your question by saying the 911 system is designed for everyday emergencies. It's not designed for extraordinary circumstances. But when the extraordinary becomes ordinary, that's where the level of demand and strain that we saw last year, specifically with the heat dome, has an impact on the system. I want to be clear that the entire emergency services system experienced that demand and strain.
That's true.
We are all in the same boat in terms of a tight labor market, in terms of recruitment and retention challenges, in terms of the fact that this is a demanding job, and it's not for everybody. And so, looking to the summer, are we concerned? Yes, absolutely. I would say that all of emergency services are concerned about what could potentially happen this summer in terms of extreme heat, in terms of increased call volumes. Tourism is back. I remember hearing on the news that there was a cruise ship that needed to have aquabuses ferrying back and forth because there just wasn't any room at the docks. It's busier here, and that means that 911 calls are going to be increasing. It means ECOM's busier. It means our partners are busier. So what have we been able to do about that? We worked last year. It's very commonly known about the challenges on the system, the delays on 911, the delays that we experience being able to transfer calls to the ambulance service, we're experiencing the exact same challenges that ECOM is in terms of staffing and resources. Together, BCEHS and ECOM put into place a temporary call transfer procedure which allows us to disconnect from some of the calls that we would normally be waiting on the line for an ambulance call taker to pick up. Calls such as requests for an ETA on an ambulance where there isn't a need for an ECOM 911 call taker to stay on the line. So all of that temporary procedure is helping to ensure that 911 calls are being answered as quickly as they can be. Currently, we are answering 97% of the 911 calls this year so far in 5 seconds or less, and our target is 95%, so we are above that. But when volumes increase to the point where the number of incoming calls outnumber the number of staff that are available to answer those calls, that does become of concern.
Thank you. Thanks, Chair.
Sonia.
Thank you so much. And just to echo Shirley's words, I mean, I can't even imagine what it has been like to be on the other end of those phone calls. I'm interested about, again, coming back to the provincial kind of role and trying to get the provincial standards, the provincial oversight, the what I would say is equity of access really should be the goal. And you identified that you're bringing a resolution back to UBCM in the fall. There is currently a review and proposed overhaul of the legislation governing emergency management in BC. Are you engaged in conversations around that legislation? And is this where that would fall? Is in that legislation, or would this be what the other 8 provinces have that you identified having governing 911 standards? Is that separate legislation from emergency management, or can you be incorporated into what is happening in terms of that overhaul right now?
It's a very good question. I don't have the answer. Those conversations are happening right now with government, but I'm sorry, I don't have that answer for you today. Yeah.
Good for us to know, though.
Do you know?
No, that's good.
Okay. Doug, go ahead.
Yes, thank you. Much of my question has already been asked, reflects the concern over capacity, but I wanted to say how pleased I am. We had Oliver Grutter-Andrew from ECOM speak to us a few times on the police committee, as my friend Dan mentioned. And I'm really, really pleased to hear so much of the report's recommendations reflected in the kind of planning language that you've used here. It's really, really reassuring to hear that. Thank you for that. And that leads to my concern over the capacity and the load that's being put on call takers. we were told that it takes somewhere in the neighborhood of 19 months to fully train a call taker. So at the same time, we're asking for expansion of the scope and a fourth option, as you referred. My concern is around recruitment and the ability to train, and what steps are being taken to enhance recruitment, with the understanding that this is a problem in virtually every sector. But thank you very much for that.
Thank you, and it's a good question. In terms of recruitment, ECOM has been aggressively recruiting for 911 call takers, and also at the same time aggressively expanding our training capabilities as well. So in terms of 911 call takers, we do have a number of new hires who are coming through also our summer student program as well, which is a great source of recruitment and talent for us, particularly over the summer months when this program is in place. It does take close to a year for a police call taker to really fully get up to speed in terms of the job, and that is a separate role from the 911 call taker in terms of the staff will do both, but they will start as the 911 call taker, and then they will move on and train to the police call taker position, and that does take close to a year in terms of getting that person up to speed. So it takes time, and I think that that's important when we look at our recruitment. It does take time for those police call takers to get up to speed there. In terms of our provincial mandate, it's really about, yes, expansion is part of the equation in terms of the capability of expanding the system through Next Generation 911 expansion based on our belief in the value of a consolidated model as part of ECOM's strategic plan. But our provincial mandate, it really is applicable to the current service scope as well. It's really meant to address the inconsistencies in terms of standardization, in terms of policy. I mentioned ECOM has more than 100 different entities that it has to work with in terms of those policies and standardizations, but having one overarching set of standards for the entire service area is where we believe there's a need to move to. And then also in terms of the provincial mandate, the funding piece, in terms of, as we talked about, local government just does not have the ability to be able to fund the service, particularly when we look at the cost that will come with Next Generation 911. And so again, having that provincial funding oversight and looking at the models that the other provinces in Canada are using in terms of that, specifically being driven by the needs of Next Generation 911, that's really driving a lot of the momentum behind our advocacy of this.
Doug, you had a follow-up?
Yes, thank you. Not a follow-up, but just a comment that I see reflected the language around, say, forestry, where, I consider it to be a really wonderful industry in so many ways, but sometimes the language around it can discourage people from choosing a career path. And I think it can be true. My friend Shirley mentioned, in a nonpartisan way, the reflecting on the challenges and understanding that we do live in a competitive partisan environment politically. And I fully expect that she, as much as anyone, will be stern in her review of and critical as the opposition should be. But I also hope that this opportunity for NG 911 is something that will excite the imagination of young people who really will appreciate the progressive technical advancement of all that. And hopefully you'll be able to recruit people who have that kind of interest. And I know that all of us will be doing our best to support that. Thank you.
For you. I wanted to dig a little bit deeper into the opioid crisis and the response that the role that you play and what that is. So from what I understand from your presentation, if you receive a call of somebody that's experiencing an overdose, you would pick up the phone but then transfer it to whatever the appropriate service is. Is that correct?
Yes, that's correct.
How it works.
Yes.
Okay, so I wonder if you have any insight for this committee, particularly about the responding to the opioid crisis, of what you think might be a better way to respond or adjust, or something that would feed into what we think we would be recommending to the government when it comes to our response to this. Is there anything particular there?
I'm a little limited in terms of what I can say around that, simply because we don't handle the overdose calls specifically. Those do get transferred to BC Emergency Health Services. On the fire dispatch side, the agency's fire departments that ECOM dispatches for are often called out to those calls for assist. Where the impact really does fall on ECOM is just in terms of with overdose calls and the increase in overdose calls that we're seeing. That means 911 call volumes are higher. So in 2021, when we know volumes reached historic highs, we know that within that, the ambulance service saw extraordinary increases in terms of their call volumes. Before that gets to ambulance, it hits us. And that's the broader 911 piece there in terms of the impact. Where we do see opportunities is really around looking at what alternative response measures could look like for those calls. I would have to defer to my friends at the ambulance service in terms of more specifics around what that might be and what that might look like. But it is connected into the capabilities with Next Generation 911 to offer something that goes beyond just the traditional police, fire, and ambulance, that could potentially help with the crisis in that regard.
Mm-hmm. So the more flexible, what you were talking about, ways of looking at culturally appropriate responses or community responses or engagements that might come with the next generation technology.
Exactly.
In terms of response options.
Exactly, yes. And the consistency of standards in terms of how are those calls responded to as well. Mm-hmm. Yes.
Okay, thanks. So we have about 8 minutes left and 2 more people that had questions. So let's see if we can get them. Well, we might want to have a little break in between our next speaker, but we'll go. Go ahead, Susie and Runaway.
Actually, I'm fine. Thank you.
You're fine. Okay. Runaway, go ahead.
Thanks. Just that last exchange brought up something for me, and that's, I don't know about most people. I think it's true. You make a call and you have to go through a menu to drill down to getting your needs met. And when you dial 911, nobody expects that. Right. And so the value of that human ability to respond is just so critical. And so it makes me, since we're on the record and there's an opportunity here in terms of recruitment, when it's value, it's such a valuable service and something that everybody in British Columbia values. Is there there's an opportunity here to just talk about that recruitment situation that Doug was referring to, about what kind of values and what kind of talents and skills are you looking for when you're seeking out your dispatch caller receivers?
It's a great question, and I wish a member of my People and Culture team were here to answer it more eloquently than I can, but I'll give it my best. This is such critical work in terms of the services that are provided by 911 call takers and dispatchers, in terms of the importance of that role for public safety as a whole. It's demanding work. It's not for everybody. It's fast-paced. It's dynamic. It's stressful. The ability to decompress after your shift, to not bring home what you've just gone through in a 12-hour period with you. It's challenging. It takes its impacts mentally, emotionally. That's why ensuring that we have the best mental health supports available to our staff, including trauma-informed counselors and our critical incident stress debrief team, and all of that is critical to our organization and a priority for enhancing the current offerings that we have. This is purposeful work. So when I think about our staff and what drives them, it's that purpose. It's that being part of something bigger and that's important. It's knowing that at the end of the day, after a 12-hour shift where you took some of the worst calls you've ever dealt with in your career, that even on those hard days, you know that what you've done has mattered and made a difference into the lives of people who have called for your help. Our staff recognize that it might be the thousandths of calls that they have taken that comes in through the beep in their ear, but for that person, for that beep in their ear, there's a person at the other end of the line, and for that person, this is potentially the worst day of their life. And so having that empathy in order to really understand that, being able to take charge of the situation when it's dynamic. They're not only looking out for the safety and well-being of the callers and the public, they're looking out for the safety and well-being of our first responder partners as well, wanting to make sure when they arrive on scene that they know exactly what they're walking into for their own safety. Being able to multitask and work quickly and really rising to the occasion. I mean, even when I think about the challenges of last year, what continues to just amaze me is how our team really, it sounds cliche, but it's a family, and we bonded together, and the staff were there to support each other. And so knowing ECOM is understaffed and under-resourced, and that our people are having to take on too much overtime, they're taking that overtime on because they know that it's helping the public and our first responders, but it's helping their colleagues as well. So it's important work, and that is really fully understood, and it shows up every day when I'm out on the floor and I see our people and how they're doing. It's incredible, and it's very fulfilling work as well at the end of the day. Thank you.
Thanks, Jasmine. And on behalf of the committee, I think you heard a lot of committee members just express how appreciative we are of the important work that the responders do for British Columbians across the province, as you said, at their time when it could be the worst day of their life, and I appreciate the toll that it's taken on everybody. So just want to send that message to your crew that you have a bunch of people that appreciate that work.
Thank you very much. I'll take that back.
Thank you for coming and talking to us and helping us learn about the work that you're doing.
Thank you.
Yeah. So we'll start in about 3 minutes with the next round. I'm going to go to the bathroom. Back. Our next guest is Johnny Morris from the Canadian Mental Health Association BC Division. Welcome, Johnny. We all have your presentation on our screens through SharePoint, so we'll be able to follow along that way. You have about 20 minutes to present, and then we'll leave 40 minutes for questions and answers, and we'll pass it over to you.
Great. Thank you so much, Chair. Well, it's an honor to be here and a pleasure to be here and a privilege to have been invited to present to a committee that's undertaking such significant and important analysis work, heavy lifting in subsequent recommendations around a profound and devastating loss of life that we're seeing across the province right now. I do want to acknowledge I'm joining you here today on unceded, unsurrendered, ancestral Tsleil-Waututh, Musqueam, and Squamish territories, and very privileged to be doing that this morning with you. And I think it's important. I've read the materials you've had presented to you as a committee in the lead up today, and you've received a lot of data about lives lost, profound loss across this province, across many, many communities. And I think it's just so important to preface my comments with acknowledgement of those losses and the fact that currently there are hundreds, if not thousands, of people grieving across the province for multiple kinds of losses, not only drug poisoning related losses, suicide related losses, heat dome related losses. And so there is a profound time of loss right now. And sometimes statistics can desensitize us, I think, to the gravity of the undertaking that you have in front of you as a committee. And I think as part of the conversation, my hope is we can turn to some of the needs and the imperative around grief and bereavement support that often is in short supply in the community mental health context. So I work for the Canadian Mental Health Association, and I won't linger here for too long. Sometimes we are confused with the Canadian Mortgage and Housing Corporation, which is less than ideal right now given mortgage rates. But I do work for CMHA. We're one of the most established national charitable organizations in this country, and so we've been in operation here in BC since 1952. And we really do hold a vision of mentally healthy people in a healthy society. So we bring a strong social determinants lens to our work, and you'll hear more about that as I move through the material. And I'm the CEO at the provincial office, and we have 14 branches serving over 100 communities, many in which in your constituencies. Many of you know my executive director colleagues across your regions. So what I thought I would do in the remarks I have for you this morning is just very quickly get to our positioning around some of the issues that I think are at the heart of this. A significant amount of the important conversation and planning and action around the drug poisoning crisis in this province is around decriminalization and access to safe supply. And you will hear, and you've heard from many experts in this space. You've had many presentations with the health authorities and the ministry, for example, and I can absolutely comment on that. But I do want to start by saying CMHA is very much in support of decriminalization of substances and enhancing access to safe supply in this province. I think there's a moral imperative to act there when it comes to a poison drug supply, and our positioning is there. Happy to add more to that, but what I wanted to turn to today was kind of broader context around the crises, the multiple crises that we're facing, and posit some possible routes of action for this committee to consider. So on one of the slides, there's kind of 3 bullet points and a fairly heavy title there around crises of deaths of despair. And I'm being deliberate here in framing that in this province you have other public health related deaths that we need to grapple with, including suicide, including alcohol related deaths, and including the drug poisoning crisis. And the way I'm coming at this is, as I mentioned, CMHA very much believes in tackling the social conditions in which people live. We really need to look at livability, the livability of lives. Do the conditions in which people live contribute to experiences of despair? Because what we do know from epidemiology and research is that when despair is present, we tend to see injuries, we tend to see fatalities, we tend to see very poor outcomes. And we recognize the absolute need for treatments and support in this province. We absolutely need more appropriate, more accessible, more timely supports. But I think this table recognizes ultimately we won't treat our way out of all of these problems. We won't problem solve our way out of this with treatment alone. We absolutely need to look at the social conditions and the material circumstances in which people are living. And Death of Despair is a framework that was first provided by economists Ann Case and Deaton out of the US. And it may not be the right context here in Canada, though at the University of Alberta there's some interesting research around this, looking at the number of excess deaths that we see across this country. And BC has seen a significant, and if you've heard from Dr. Reka Gustafson, you'll likely see this data very well laid out, excess deaths related to not only COVID, but also opioids, alcohol-related deaths, and suicides. And their framework very much thinks through the circumstances in which people are and how we can tackle inequity in those conditions in preventing loss of life. You've had lots of data this past few weeks, 9,400 lives lost since the declaration of the public health emergency for opioid-related deaths. There were many lives lost before the declaration of that emergency, which we need to remember. Every day in this country, according to data from a few years ago, 8 Canadians die in hospital from conditions entirely caused by alcohol. 240 hospitalizations each day across this country caused by alcohol alone, as many as 16 children and youth a day hospitalized. And BC is one of the poorer performing provinces when it comes to hospitalization rates related to alcohol. Back in 2019, about 367 per 100,000 hospitalizations were entirely caused by alcohol, a very readily available and regulated substance. And what we know is that during this pandemic, the data we've collected, we were one of the first organizations to collect multi-wave pandemic data, so trying to look at the impact of the pandemic on mental health. The data we have shows substance use, alcohol use has all increased over that time. And so it's critical we look at drug poisoning deaths, but also alcohol-related deaths is a significant issue that we also need to grapple with. And then finally, this is an issue I've been around for 25 years. I know there's a member of Parliament in Prince George who cares deeply about this issue too, around suicide prevention. There's a number of folks across the province who really have been calling for change in this area. 2021, 582 lives lost to suicide. In 2020, 597. In 2019, 634. Island Health is the only health authority to have seen increases year after year since 2019. And the age group 30 to 39, we've seen increases since 2019. There's always risk relying on single years of suicide data. You want to look at time, things over time, and the Coroner's Service has reported a drop. What we do know about suicide, though, it's a lagging indicator, very much linked to people's experience of livability, economic inequity. It's not only mental illness, and we really do need to keep an eye on those pieces. So between drug poisonings and suicides in BC alone, last year we lost 2,806 lives. That's not including alcohol-related fatalities. So what I'm trying to do here for the committee is broaden the lens. Broaden the lens that if we look at 3 indicators around lives lost, deaths of despair, hopefully that broadens the sites of action that you might consider in your recommendations going forward. So for this next part, I'm just going to talk about some of the roots of this, and we've been at this for some time, and you'll see in your material a slide headed Drivers of Adverse Wellbeing and Underlying Pain. And what I think when it comes to responding to complex phenomenon like lives lost due to suicide or drug poisonings, we need to think in a very multifactorial way. We need to consider chronic pain. And I think you've heard lots, or you will hear lots, about the relationship between pain, physical pain and drug poisonings. But there's all sorts of kinds of pain that people experience, which can lead to substance use, which can lead to death, that we need to consider. And they include adverse childhood experiences. If you haven't heard of ACEs before, these are the ways that very early on in life, adverse events can stack up and really affect the trajectory of our lives. So experiencing child abuse and neglect, violence in the home. A good way to long-term prevent drug poisoning deaths is to implement provincial trauma prevention strategies, violence prevention strategies, systemically looking at reducing adverse childhood experiences. You saw in your slides from the Ministry of Mental Health and Addictions, and there was a very important discussion around people living on income assistance or in poverty and the relationship there. Persistent and prolonged stress in childhood. So living as a child in poverty can create trajectories that lead to all sorts of outcomes that we want to prevent. Discrimination and racism as well. You've heard throughout your testimony, and economic inequity. The more economic inequity that people experience, the poorer some of the outcomes can be. And so what I've done here is I superimpose, you had a great slide from the Ministry of Mental Health and Addictions earlier this week, and you saw these stats of 33% times more likely people living in extreme poverty to die by a drug poisoning. Recent release from prison, First Nations disproportionately represented. All of those factors there relate to things that we can intervene with much earlier on in people's lives from a prevention perspective, but also from a settings perspective, communities, schools, educational settings, families, etc. And I understand that that can feel very daunting when you're faced with the death rates you're grappling with here as a province. How do we think about prevention at the same time as stemming a devastating loss of life over here? And it requires bold action at a provincial level, of doubled action, both prevention and also intervention with the loss of life later on. So here on the prevention despair slide, I've offered some ideas from the perspective of our association, and we've been in the space of some of this work for many, many years. Modernizing pain treatment and management. There's lots of experts in this province that will help you with that, and we have a long ways to go before we've truly dealt with workplace-related injury and disability prevention and all those pieces. Decreasing adverse childhood events, very, very key. Work underway, I think, in many areas, but how do we scale and deepen the efficacy? How do we avoid tinkering or incrementally making those changes given the imperative that's in front of you? Systematically, we have not had a provincial suicide prevention strategy in this province, I don't think, ever. We don't have one in this country. Like, systematic efforts to look at the prevention of suicide is a marked absence in our public health infrastructure. We've tried, but we can do so much more there. So systematically looking at how we can prevent suicide through a strategy, I think, is very, very important. Reducing stigma, you've heard lots about, and enhancing school-based efforts focused on education and recovery. So this presentation isn't about CMHA, and it's not about showcasing our programs in any shape, way, but I do offer three things here that I think are just case studies of early intervention prevention work. So there's a slide labeled case studies in your PowerPoint deck. So we have a program that we've operated, and you heard about it, I think, from colleagues at the Ministry of Mental Health and Addictions, called Confident Parents Thriving Kids. And we reach thousands of families each year with this particular program. We have a wait for service now because we've seen demand absolutely skyrocket. Parents have more anxious kids. Parents have kids experiencing more distress. But this program is profound in its impact. We provide people-powered support, and I remember MLA Leonard's comment earlier about human-powered care, like the ability for a human to connect during a time of crisis. We do the same. We provide human-powered care to parents of young children who are experiencing behavioral problems related to attention, cooperation, and conduct. And across all of those indicators, these kids move. They go from a red zone of high challenge around conduct or high challenge around agitation and behavioral problem to a green zone. We move with the program and with the work of parents, kids from red to green. And of that, what we see is kids longer term, and we've been at this since 2015, when we're studying this actively, kids less likely to be excluded from school. So if you're excluded from school, your life chances start to shift significantly. And there can be trajectories towards heightened use of substances, mental health problems, etc., because despair can start in many, many ways. So this is a good example of getting to kids at actually age 3 to 12, and actually mitigating some of those outcomes longer term. I would say Confident Parents is a despair prevention program. It's a suicide prevention program. It's a positive parent program, but underneath it, we're trying to achieve those aims. Links to employment, we've been at as a bit of an experiment of trying to bring employment support, psychotherapy, so access to counselling, to primary care. We've been doing this as a pilot for about 18 months on behalf of the province. And this program is for folks who are on PPMB, so that's persistent and multiple barriers. That's an income assistance category. It's often a classification of disability income assistance where you kind of sit and languish for some time, and also persons with disability rates. And what we've seen, when you have primary care, and there's a shortage, I do get that, but when you have primary care integrated with occupational therapy, counselling, and employment supports, you see amazing outcomes. The people we serve meet all of the risk characteristics you saw in that slide at the MMHA. They're on disability, they're experiencing poverty. But when you put people-powered care around them, we've seen folks move, we have a 57% rate of those folks moving from those disability income classes into employment. They're actually in training. So again, despair prevention. We're changing the material circumstance in which people live. It's not the panacea, but what we do know is when people can make their ends meet, when they're not struggling to make ends meet, when they experience dignity, respect in work or volunteering or training, things can remarkably change. So it's just another example of despair prevention, in my view. And then you've heard earlier that we've we're an administrator. We don't provide the direct service, but we've managed to establish 105 beds across the province through a network of 14 providers with a one-time only grant, and we converted a few private beds into public pay, but the rest were public beds. And we've actually seen, because I know there's a challenge sometimes with the data in those treatment and recovery spaces, because we're the intervener, we've been able to kind of spend time with those operators and really see an 83% occupancy rate, so people stay in those beds. They are staying in those beds because there's nowhere to discharge in community sometimes, so that context of care is challenging. But the beds are not sitting empty. 484 admissions last year, 199 came in an OAT. We really wanted providers, irrespective of their orientation to care, to make sure they weren't creating harm by taking people off OAT or opioid agonist therapy that you've heard lots about. So we see fairly good maintenance of OAT through those folks, and about a 40% rate last quarter of folks self-identifying as First Nations, Inuit, and Métis. And so the providers we've been able to work with have targeted their services to respond in culturally safer ways to those populations, which has been great. So it's a grant, we're the administrator, but we've collected really important data about what's needed to make sure that people bridge into better care. There is a lot of work to do there in and around those community-based beds. So in the balance of my time, and it's rare, I was at the Finance Committee the other day and 5 minutes flies by in front of your colleagues at the Select Standing Committee on Finance. To have 20 is remarkable. And clearly I can take up 20 minutes with great adeptness. So, but finally, in my recommendations to this committee, I admire the engagement of this committee, and I know you're grappling with profound volumes of information and data. I mean, you're sitting amidst folks at the forefront of a crisis, and you're likely going to hear from lived experience, and you're going to hear from substance users and service users. So when it comes to recommendations, I'm sure you're grappling with many already in your minds. The first thing, I'll do the last one first, strengthen. I think you all know the imperative to act here. We need to strengthen the response to the profound and immediate risks of the poison drug supply. That is absolutely where we need to see enhanced access to safe supply. We need to rigorously evaluate those thresholds under the decrim piece to make sure that there's no unintended consequences there. And I think that work is under active debate in the House, at committee tables, and inside government. And we need to see sustained action there. The top end, I've said here to develop and adopt a provincial strategy. I say that with some caveats because I think there is strategy fatigue. We have a lot of strategies out there. But I do think there's an opportunity to either update the existing strategies that are in force. I know we have Pathway to Hope, but really look at systemic ways that prevent and intervene with pain and despair that is responsive to the time we're living in. That heat dome, 2/3 of the people who died during that heat dome were people living with chronic illnesses, including schizophrenia, depression, and anxiety. Climate change impacts people with mental illness. It can cause a mental health problem. We've heard all about that. But these things that are happening around us do disproportionately impact people living with disability, living with mental health problems, much more than the general population. And we need to attend to that, not in one-size-fits-all ways, but in very targeted ways aligned with the evidence. And you have a lot of work underway. There is work that is underway, and there's novel work that needs to get started with investment and time and money. But to scale existing preventive and early intervention efforts that show strong outcomes in the prevention of despair, I think is a very important call to action. There are hundreds of recommendations that have been made to government over the past 5 years. Coroners, the Special Committee on Police Act Reform. There's so many recommendations that even sitting with those lists of recommendations and consolidating them into the 5 that are going to make the biggest impact over the next few years might also be a prudent way to move forward. With 19 seconds to go, I will stop there and hope. Oh, thank you. Thank you.
Yes.
Thank you.
Johnny, I think that's a first. You came in just on time.
Well, I was in red light prevention.
Yeah.
I really wanted to make sure that.
No, we appreciate all your.
Yeah,
all your,
that's another. No,
Okay,
it's another
so
15 seconds you've got.
We'll move to the discussion portion. I have Sonia, then Dan. Go ahead, Sonia.
Thank you so much, Johnny, for this presentation and what you bring to it. I think I'm reflecting on what we heard from Guy Felicello last night and the role that trauma therapy has played in his recovery and how important that continues to be. And he talked about, jurisdictions where that therapy is accessible and covered. And you say develop and adopt a provincial strategy. I think I'm going to push you on this, but when our local CMHA is doing fundraising with silent auctions online, you're going to the health committee and saying, please keep us going. To me, what is apparent is we are not valuing the role of mental health care and preventative mental health care in addressing this and so many other crises. So I'm giving you an opportunity to be a little stronger about what you think is needed in terms of how to get access to mental health care for everybody. There's a proposal from the BC Psychological Association to incorporate minimum 6 visits, a year to a psychologist. We, I think, need regulation of counselors and therapists in this province. But I'd like to hear from you just what is needed to be able to counter the despair with accessible mental health care.
Legislated parity. So legislation. And it starts, and this is the tricky part of kind of federated health delivery. Mental health money is the softest money in the economy. Like, it's the first thing to be cut. It's the hardest dollar to track. And we're not where we need to be around parity. And so, we have these mental health transfers that are meant to be coming from the federal government. I think through my federal colleagues, there's some ambiguity, around when those transfers will work. We do have a historic attempt from the federal health transfer to level up mental health resources, but it's not legislated. And we've called nationally, and I'm not sure what we could do provincially, to legislate parity, because under the Canada Health Act, mental health money is restricted and protected around hospital-based mental health care, psychiatric hospitals. There's no protection for community mental health dollars, really, in that transfer. The UK legislated parity of esteem. So a dear colleague of mine, the Right Honourable Sir Norman Lamb, he was the health minister there for a while, and under his watch, he's a brilliant person to spend time with. He managed to legislate what is called parity of esteem into the NHS, the National Health Service Framework in the UK, and also now they're nowhere where they need to be, but there's an important kind of, I think, legislative assumption that funding is allocated in particular ways, and it's not about creating a $27 billion mental health budget alongside the overall health budget. But it is around legislating and protecting funding for access to things like community-based counseling, because mental health and substance use money is so vulnerable. It's one time only. It's grants. It's easy to kind of obscure in that overall health spend. We keep an eye on that $2.2 billion that's allocated in the overall health spend in this province to make sure it doesn't start to shrink. the Mental Health Commission and others have recommended a 9 to 10% allocation. So I think thinking about legislation, the U.S. has parity acts to prevent insurance providers from discriminating against the provision of benefits related to mental illness and substance use. But I do think legislating it is an important way forward. And where that happens, I'm not a legislator, I leave that to you, but federally or provincially, there's some thought there. We have to ring fence mental health and substance use dollars. The fence currently is kind of a few little gate posts and a very large open gate in and around those funds. I think parity as a lens, Emily, first note, is also helpful because it kind of predicates that when you go and experience a primary care visit, you should experience the same standard and level of care if you're going in for a heart problem as if you're going in because you're hearing voices or you are, so parity is a very helpful legislative and regulatory framework. And the last thing I would say is there's the regulation issue you raised. I was at a recent forum lately where there's a huge emphasis on quality in the physical health system. There's an expectation if you go for surgery, you don't leave with sepsis or, additional injury. We do not see the same quality frameworks as deeply in and around mental health care. And so you could just see how parity could really ring fence this. And I think that would be the starting point to start looking at how you allocate MSP to pay for. So I appreciate the nudge and feel free to nudge away. I'm happy to be nudged. We really do have to protect and ring fence where we can. Was that helpful?
Chair, thanks, Joni, and good to see you again.
You too.
Kind of along the nudging line of Sonia, but more specifically around children. We've been hearing lots, with children's mental health issues have obviously increased, especially during COVID, which is really concerning. And you talk your one program that you have. The Confident Parent, Thriving Kids, as one piece. Mm-hmm. Let's say money's not an issue. What is the best path forward to do what we need right now? Because these are the kids, this isn't something we need to study and look at and, 3 or 4 years down the road come up with a solution because it'll be too late for a large group of young people right now. What can we do right now to, work with the education system, to work within the Ministry of Mental Health and Addictions, Health, and other ministries that, cross all over these pieces? What can we do right now that would have the biggest impact to benefit these young people that are struggling right now?
Do we have all day for that one? That's a good question. I mean, I think you've probably heard so much about the challenge across systems for them to work together, right? And I do think often, there's an inability to make the meaningful change because you've got to get all these systems to play in the sandbox and share information and actually unite around this priority. And that's hard to say, but I think the moral imperative is we have to get out of our own way and find a way for that, and I absolutely think there is evidence that some of that is underway, but to kind of get in and around and share that unified vision, irrespective of which ministry, service provider, we see it in the nonprofit sector too, that getting to kids, young kids, and we respond to kids age 3 and up, is just so critical right now. There's good examples around responding to the fact that kids are experiencing trauma. They've experienced trauma during the pandemic-related trauma. And there are things that you can do really, really early on to prevent the worsening of that trauma. Clearly, you heard from Guy just around the value of trauma intervention. These are not fait accomplis. We can intervene in people's lives and alongside people to shift those trajectories. What can we do now? We can see that you can promote and support mental health and intervene with mental health in so many settings, right? Schools, workplaces, communities, families, and to really double down on, it doesn't have to be the treatment room where you can provide care. There's just so much that we can do in K-12. There's so much that we can do in universities and colleges going forward. I think if as I sharpen my pencil a bit more here, Emily Davies, I think we absolutely have to not study how long it takes for people to get here, but arrive at the conclusion that waiting for 12 months for care, if you have stage 3 cancer, you're dead, right? In this case, if you're waiting 12 months for mental health care, you might also be dead, right? The outcomes are different. So we have to get to a point of, and we have wait lists where I have zero tolerance, but we're constrained. So we're in the same boat when it comes to wait list. But how do we draw a line to say this wait is grossly unacceptable? It's not okay, and we're going to do everything we can to make sure that there's less wait or no wait. And the challenge is across this country, there's no, if any, jurisdictions that actually study the wait that we have for people. So understanding that if you're waiting for care, people are deteriorating. All of those opportunities are lost to intervene in those people's lives. So I think that probably would be a good conclusion. We must stop allowing people to wait for care, and we have to get care to them somehow, some way. Was that helpful too for your question? Feel free to nudge
I'm sure you
further.
could probably go much deeper and very pointed, but yes.
Mm-hmm.
Go ahead, Trevor.
Actually, the majority of it's been taken by Sonia and Dan, and it is around affordability. And to Sonia's comments yesterday is Guy gave the example of that if he didn't have trauma therapy, he'd be, in his view, dead. That trauma therapy is obviously very, very expensive, and he was public about it yesterday, is that he's now on a sliding scale, right, in order for him to attend. And he said at the beginning is that you really have to go heavy in the beginning to deal with everything kind of up front, and then you go from there. So I think everybody agrees from a humanistic point of view that we have to find a better way, right? This has been a problem that's been going on for decades, and we have to find a better way to get people access to mental health supports. Have you ever come across things from an economic point of view that would show you the impact of getting people that access to that supports and how that benefits us overall in terms of not having them having to rely on additional supports later on, right? I know from a humanistic point of view, we understand what the right thing to do is, and we're not there yet. We haven't been there for a long, long time. But from an economic point of view, have you guys as an association ever looked at that?
Yeah, I mean, I'll have to fact check this and maybe correspond back with the committee in case I'm wrong, because it's been a while since I've been in the data. But there are very rigorous economic evaluations that underpin, Emily Halford, your comment that currently you're paying for it in the most expensive ways possible. Every police visit to someone in crisis, every RCMP officer that sits in the ER for 6 hours, every jail bed, like the vast proportion of people in provincial jails right now are identified to live, I think the percentage, latest research, 70%. So we closed Riverview and we've just reinstitutionalized folks in prisons, right, as trans-institutionalization. So I think we all just need to conclude you're actually paying for it in the most expensive, profoundly expensive ways possible right now. For every kid we divert and confident parents having kids from social exclusion and contact with the justice system, it's an over lifetime cost saving of about $250,000 saved. Diverted per child, diverted from the system, who might have been on a trajectory for exclusion. You know, and I can find that research and send it into the committee. Every loss, every without boiling it down to crude economic terms, but every one of those deaths of despair is lives lost of contributing lives, like not just economically, of course, humanistically and socially. Yeah, if you can get to someone and early on in a trajectory and you're not sending first responders to a crisis situation and then they're hospitalized for 30 days, you know, those are profound cost savings. So there's been a lot of work to demonstrate, you know, the return on investment of preventive, early interventive supports. And we actually did an analysis 5-6 years ago that kind of tried to compare. We were using the language of before stage 4. So if you think of stage 4 cancer care, very expensive, very invasive, very challenging options, and you can apply the same logic to mental health, right? It's crisis, you've got hospitals, acute care, inpatient visits. And you're already paying for those in profound ways. Like, what's a jail bed per year, in this province? A lot of money. The challenge, I think, and I've heard this before, is the way government's set up, right? So your appropriations are set up. You've got MCFD, you've got health, you've got, and so those appropriations are challenging to say, well, I'm going to save the justice system. So we have 10 kids, we divert over 10 years, and we've saved, what's that, $3 million. Like to say to another ministry, I've saved you that money. I'd like that money. It's hard in the current setup of your appropriations, your estimates structure. You're all investigating estimates against dedicated appropriated lines. Other jurisdictions have looked at kind of health in all budgets, right? Really looking at the common treasury in a different light, in a different way, so that you can say across the cabinet table, I've saved you $500 million during the course of this administration. For budget, whatever, let's add that in currently. Because I think just arriving at that conclusion, you're already paying for it, but you could pay for it in different ways. So I think it's an excellent comment, Emily Halpin.
Okay, we have lots of hands up. Let's try to get through as many as we can while we have you. I'm going to go to Susie. Go ahead.
When you look at Canada, are there provinces, how would you put BC relative to the work that's happening in other provinces in terms of the mental health support and in terms of your outline of the deaths of despair? And specifically, let's look at opioids, since that's,
Yeah, it's a great question, Emily Chan. I mean, I do have to say, and I know there's often lots of conversation, but to actually have, and it's good to see the feds do this, a dedicated point of cabinet accountability around the mental health, to actually have a mental health ministry is very important on the outside. Full disclosure, I worked there for a little while. But to have that access point it makes it easier, I think, to start to peel out. There's a different level of accountability and transparency now around some of these things. You're not sitting in front of someone who's also accountable for hips, hearts, eyes, hospitals. You can actually allocate that. There's lots of recommendations we could have around emboldening that in the province, and that likely has to happen. I think in the province on the spend, I think BC, I think is favorable in some areas in trying things out. So, there was one of the largest investments, we administer it, around community counseling. That's made a profound difference for thousands of lives in this province. There's money that's gone into community agencies, including CMHAs, to provide low cost or free counseling. And I'm not sure of how across the board that is. There's good opportunities around Foundry and integrations there and what have you. But I think we're in a particular space when you look at BC. So we're the worst performer in alcohol-related hospitalizations. There's a lot there. On the suicide rates, we lose 500 lives a year. So that's 737, 747 crashing every year in BC. I think we stack, fairly equivalently across the country. We have, I know I'm deviating from opioids, but I think we do have a serious issue around involuntary hospitalization. 20,000 people involuntarily detained in this province 2 years ago, which is a very significant increase when you compare it to 10 years ago. It's, I think, a 40% increase, something like that. So I think the challenge we have in BC is more and more people are getting to a point of crisis and needing involuntary care options. But I'd have to pull more data we used to do more of that cross-jurisdictional analysis. But I think BC on the opioid deaths it's one of the hardest hit. Most recently, MLA Chant.
So I'm hearing from you, I think, that having a Minister of Mental Health is a big step forward relative to other places, because it allows a better focus and it allows a wider gate.
Yeah, it started a global trend, right? Yeah. There's ministers of mental health and addictions popping up everywhere. Again, emboldening that ministry with the legislative authority, the spending authority, and the mandate to make meaningful change is likely the way it needs to go. So again, it's back to my response to Emily Firstner's comment earlier around parity, right? Right. Do you have equal clout at the cabinet table when it comes to making the changes, going forward around these very complex issues?
Thank you.
Shirley, go ahead.
Thank you for your presentation, and you're right. You have, incredible teams across the province, Maureen in
Yeah.
Prince George, and I'm looking forward to attending an event with them, I think, next week. That's going to be fantastic. It's Ride, Don't Hide month as well, so I'm happy to participate in that. I just want to thank you for the emphasis in your recommendations related to prevention, early intervention, because I think that as we look at a full spectrum of recommendations, there does need to be the full spectrum included, which includes early intervention, in education, and recovery at the other end. So you talk about scaling up existing preventative and early interventive efforts, and also expanding school. I thought that was important too. Programs enhance school-based efforts. And I thought the supporting positive parenting was also really important. And ironically, that's what Guy Felicella talked about last night, was positive parenting and how we support that. So could you just expand a little bit on that? Because you're right, we hear all the data and we hear about all the horrific deaths. What we don't hear about is the front end that says, you know, maybe we should think about how we talk about this differently, or create those front end programs, and also recovery. It is possible. I certainly understand the challenges, you know, when it comes to opioid addiction, but it is possible. So I want to make sure we're talking about the full spectrum. So I just want to say how much I appreciated your specific comments about intervention and early education.
Well, and I think, Emily Bond, your comments really, I think, serve as an opportunity to kind of zoom out a little bit from a profound focus on death data. We have to focus on death data because that's where loss of life. But for each one of those deaths, there's an inquiry into how many doors that person knocked on, how many adverse experiences, and so that a kind of a myopia on the death incident. And I've seen this over 25 years in suicide. There's just so much that leads up to that. And I think interrogating and challenging kind of the terminality of these things, like people are literally written off, right? You have an addiction, you know, nothing's going to happen. You live with schizophrenia, it's terminal. And we forget that people can live with illness like schizophrenia and substance use problems and flourish and thrive in community when the right conditions are in place. We have lost our collective imagination, I think, around what we can put into place in community to support people to thrive. So yeah, we live and breathe prevention and early intervention work. And if you would have any of the families that we've served over the past number of years, and we're grateful for the support we get from government to do this across multiple administrations, they feel walked alongside. They feel human powered care. It's not a robot delivering care. It's a human who's trained to help parents and caregivers in the context of confident parents and thriving kids with challenges and problems where people can often feel very isolated and alone. They can talk with their GP about it. They could talk about, and actually GPs are our referring agent. We have thousands of doctors referring to us each year. You know, to sit with a parent who says, I no longer, you know, I'm no longer putting my kid in timeout, or my temptation to kind of spank my kid or physically discipline the kid is dissipated because I've learned practical skills around positive parenting. Like, it's quite profound to listen to that, Emily Bond, because it is life altering in the most positive of ways. So I think thinking of those journeys in your inquiry as a committee is really important, and thinking about the multiple opportunities we have to get to people before all that's left is an ambulance. That's the only response you've got left, or a police car. There's so many more things we can do. Did that help, Emily Bond, with your question?
Yeah, thank you.
Thank you for coming and speaking with us today and bringing your expertise. My question is kind of similar to, or builds on what Shirley Bond just asked you about. You've spoken to the Finance Committee in the past, and one of the tools that they use is, how would you spend your tax dollar? And I'm going to talk about this continuum. You hit the nail on the head, of course, about the social determinants of health, that's where we've got to start from, and building a society that's equitable, inclusive, that where everybody is thriving, so that we don't even get to a place where we need mental health supports. And then you move into prevention, and then you move into early intervention, which is, of course, a beginning of the reactive stuff rather than the building, until you get to the urgent situation and the crisis that we're facing right now, which is what brought us to this. So if you had $1, 100% of the money to spend on where we spend our money, because as government, we do try to address all of these things. How would you distribute that dollar?
So
from the beginning to the end, from birth to the ambulance or police.
Wow. Cradle to grave.
Well, I think it's a question, a beautiful and important question, Emily Leonard. I think there's a reality of likely in the beginning of which is a tricky piece given the reality of Treasury right now likely is double funding. Like I do think we're in a situation where there needs to be sustained emphasis on improving the treatment care that people get right now. So we need to kind of allocate as much of that dollar over there as possible while simultaneously ramping up that prevention dollar. So I would say if you were to think of it as a pyramid, like most of the spend is on the treatment side. Like it's expensive to have people in hospitals and those kinds of things. So we need to start inverting that pyramid gradually over time so that instead of 80% of the dollar going to treatment and 20% going to prevention, we move towards a 50-50 split. We move towards a 40-60 split with greater emphasis on prevention and early intervention, which are cheaper things. They're much cheaper things. We serve 1,500 people on $2.75 million a year, right? It's not like millions and millions and millions of dollars to do the prevention side of things. So I think there is that reality. Like I think it would be impossible to take all of that money on the treatment side and reallocate it to prevention because you'll have lots of problems over here. But that gradual inversion of a pyramid over subsequent administrations, like you've got to think 4, 8, 12, 16-year cycles in this kind of work, which is tricky in government, I understand and respect. But thinking of that long-term inversion of that pyramid would be great. And there are very good evidence-based recommendations of where prevention spending should be. We should be looking at a distinct at least 10, and I would say in the current climate probably even higher, 10% allocation of your overall health spend should be going towards mental health and substance use care. So if you've got a $25 billion health spend, you want to be as close to 10% of protect, but also the right spend within that. And really understanding what's in that spend is really important.
Thank you.
This very similar to the questions that have been asked, but I can tell you years ago, Trevor, when I was a school trustee, we were certainly advocating because we had results from I forget what the acronym was, but it was the readiness program with kindergartners coming into the system. And at the time, there was a problem with readiness in our community where we had a third of our children not prepared at all. And so there were some issues with respect to poverty and conditions and all that. But anyways, in the end, it was, I think, $1 invested was a $7 save down the road. So that was in the early 2000s. So I'm sure that that's shifted, but that was the formula that we were advocating for and investments at that time. I come from a community that has a very high ratio of mental health issues. And so we have been working at this for quite a while. And I have done the ACEs questionnaire, and I was in a sort of audience setting where we were all asked to do it. And afterwards, when I got the results, I was shocked at how many people were impacted as children, through this exercise. And so that was really an eye-opener. I guess if there is a question, it's, do we have evidence of that investment that has been made over time with respect to the early childhood? And now we know that the middle years are going through the same kind of rigorous testing, and we're seeing the same sort of results with about a third of those kids that are really having issues in school. And I expect what we've heard yesterday was all about the impacts of trauma early on, and if we just had trauma therapy for everyone, would that be enough? And so we know so much stuff, right? We know about investment. We know about, the causes, the root causes. But how do we figure out all the stuff that we know and say, okay, this is what we need to do? Because it's not like we need to study it all over again.
No more studying.
We've all had information for years about the investments and the importance of success for school-age children. So what's missing? Is it a stigma thing?
I think it's what surfaces up, right, when it comes to decision making and kind of unobscuring some of the things that have worked, right? I mean, I would invite you as a committee to have Dr. Charlotte Waddell come and speak with you. Dr. Charlotte Waddell is one of the most eminent child and adolescent psychiatrists in this country and is doing profound work in partnership with Indigenous communities. And she's been a fierce advocate for closing the gap between evidence-based care and people, closing that gap, because there's a huge gap to get, there isn't much of a gap to get evidence-based care of other kinds, but in mental health, we've often had a significant gap. There's great examples in this province, the Nurse-Family Partnership, which, sends a nursing person to a recent mom to kind of really deal with some of those very early on stressors, postpartum. There's lots of things, but I don't know if we've subsequently kind of added it all up and juxtaposed it against the death side of things and kind of put those things. I mean, we can only focus on a number of things at any one given time, right? But I mean, I think that's the work that sits before you. Reconciling. It's been studied and studied and studied. We know what to do. We know what to do, and reconciling that with the public and the family and the imperative to do more on the kind of the intervening at the very, very pointy end of things around death prevention. It's a lot to reconcile, and stigma is a huge part of this, right? Absolutely.
Okay. So thanks. I have a question for you in the last few minutes.
Of course, Chair.
So I thank you for bringing the perspective that you offered today, which is about building a system of care across a continuum that values mental health, really, as people experience all the challenges that they do in their lives. What really struck me when you were talking about, and we spoke to Guy yesterday about this idea of early childhood trauma and that pain that people are using, substances to fill, and that spectrum of supports you can build up, like when you are in that situation, to intervene. And there's a couple things that kind of struck me about that. Having learned about like 0 to 5, that brain development that happens, that is so key to being part of, all the studies that show that it's so key, and the building of like a system for that period, for parents, for caregivers, for early childhood educators, that where we can actually intervene at a very young age. And as we build out childcare, I really want to know like what you feel like your role is as an association for mental health, about how to get to the kids, like even before they enter school, right, in terms of the challenges they face, and then that period where they're kind of undiagnosed but maybe having some kind of challenges, because it seems to be pretty crucial intervention point. So I'm just curious about that interface of early years and where you see that. Maybe speak to that a little bit. I'm curious about that.
Well, and even backing it up further, just even the notion of, and I'm not an expert in epigenetics by any means, but just even around maternal health and the trajectory that maternal health sets up, right? And the structural things we can put in place around moms to flourish through pregnancy and through postpartum, et cetera. Childcare is provisioning of childcare access is absolutely despair prevention. I mean, you're tackling an economic piece, you're tackling all sorts of things within the provisioning of childcare. And then seeing childcare provisioning as a site of intervention with evidence-based things, like seeing these as all as sites, right? There's lots that you can do in that 0 to 5 age group around both programming, the role of childcare providers in understanding, mental health literacy from a young age, being able to identify how you're doing. I used to do this in violence prevention, like supporting kids who have witnessed trauma with the vocabularies to make meaning of their experience is so important, right? So childcare as a setting, and I haven't heard much, and I appreciate your question, Chair, about how you might overlay a mental health promotion lens into those childcare spaces is actually quite an interesting trajectory too. And then recognizing that you can intervene with trauma, with kids, with evidence-based programs, kids who have experienced trauma, in profound ways early on in life. So I would agree with you wholeheartedly. Childcare is a site for prevention and early intervention and intervention, absolutely.
Okay, thank you. So we have about 3 minutes to spare with time. On behalf of the committee, I just want to thank you for not only the work you do for the province and the people that need it, but also just coming here today and really showing your passion for helping people go through mental health challenges that they experience. And I know that's a big issue that we need to do a lot of work on. So thanks for your time.
Well, thank you, Chair. Thank you. Thank you. And I've been at many of these committees over the past 12 years, and a lot has shifted just around the discourse at these tables, and I applaud all of you for leaning in on really, really tough issues. We didn't have these conversations as much 15 years ago. So to be at a table for an hour with you is a privilege. So thank you, Chair.
Okay, so we'll be starting in a few minutes. So on behalf of the committee, I just want to welcome our next two presenters. We have Tom Littlewood from Dan's Legacy and Jason Lesser from Pacific Community Resource Society. We also have here Barbara Coates from Dan's Legacy. We want to welcome you, and we really look forward to learning from you, from your experiences. And each of you, I think, is set to have 15 minutes, and then we'll have about 30 minutes for a discussion afterwards. And if you provided us with slides, we have them on our various screens, but if not, no worries. Go ahead. I'll pass it over. I don't know who's going first. You'll have to.
Sure.
Okay, sure. Go ahead.
Dan's Legacy is we're growing quickly, but we are quite a small and new organization. About 11 years ago, Dan lost his life to a drug overdose, and he went through 2 really expensive 12-step abstinence programs, and they thought they did everything they could for him, but he still lost his life. So they got hold of me. The family it was just edging off, and I felt I had enough gas in my tank to do something. I'm 71, so you take on new challenges at 65. So I said, okay, I'll help you, but I'm not going to fundraise for you. I'll develop some programs that are necessary, that if they existed, Dan might still be here. And let's let that be his legacy, that these programs exist for other kids that are in the same situation. So I went off, we did a pilot, and I'll do this really quickly to get to the meat, but with 3 programs: a recovery program, an alternative high school for little gangsters, and Aunt Leah's in New West, the program that helps kids out of foster care. We saw within a couple of years a 50% increase in graduation in the high school. It doubled, okay? The recovery rate doubled, right? And Aunt Leah's now, we have a therapist there every day of the week, as well as in New West, as well as downtown, and we're seeing about 150 of their young people on a regular basis. What we found is that, trauma-informed practice is what we're talking about. And it's really a term that's become so overused. I mean, I used a joke with the kids I talked to, because they've all heard trauma-informed, and I said, well, there's trauma-informed toilet paper out there now, and they'd laugh, because they're 15, 16, 18 years old, and they see the humor in it. There's a little bit more than humor in it. It's kind of got to the place now where we were working with the doctors of BC, and they're asking us to give them a definition of what trauma-informed practice is, because they're all big doing their ACE scores, the ACE thing, they're really getting into it, but what do you do with that information once you have it, especially if you're going to be prescribing an opiate? So anyway, we got to a place with these 3 programs, and we felt we really have something here, because we were really seeing some changes and the kids were getting involved. And we brought it to the provincial government, and the provincial government, through the new Ministry of Mental Health and Addictions, funded us the first year, and then the second year. And we always kind of hear, like on the 31st at 3 p.m. in the afternoon, you're funded for the year, and you breathe again, It would be nice to have multi-year funding. It's really hard to get high caliber therapists if it seems like piecework, right? We got a year at a time. They're looking at careers, they have families. So anyway, we got that funding, we got the next funding, and then 2 years ago, we got a major fund. And it was great because we really wanted to grow, but it kind of was really hard to grow that fast because we were a small organization. So we went from a team of 4 therapists to 12 therapists, and an outreach team of 5, 2 social workers, 3 outreach workers. And along the way, we have a fitness program, a food security program. We have a training program in food, and we have cultural workshops for the Indigenous youth. And we just got back from a cultural camp at Camp Potlatch, and we had about 50 people over there, and we were going to canoe, but you'd have to, it would be a pretty wild canoe ride with kids. So we took the launch over, and they canoed when they were over there. But the big thing was getting them into the rituals, the sweats, and the bathing, and all the different cultural medicines and stuff that these kids need to be able to identify with. Many of these kids we work with, they're lost. They don't even know who they are, if they're Indigenous or not. Sometimes their parents, when they adopted them, wouldn't tell them because they felt that would be a hindrance if the kids knew. But kids really need to know this stuff. So we got to this place now where we have this team, and we're just setting up now a partnership with Children's Hospital Burnaby General, Royal Columbian, and Surrey Memorial. We've done a pilot with them, but COVID kind of interfered with the pilot. Not much can happen in hospitals right now, especially if you're not a doctor. So we're firing this up again. It's an on-call system where in emergencies they can call us, because a lot of these kids, as soon as they're conscious after their overdose or self-harm or whatever, they want to get out of there. And they would like at least to be able to connect them to a therapist, rather than before. The social worker would call us from the hospital and say, Jimmy's on the loose somewhere in Strathcona Park, can you go find him, right? And we're walking around Strathcona Park going, Jimmy, good way to get mugged. And so this is a much more efficient system. About 50% of the kids tell us to take a hike, but at least they've got someone to tell that to. And before we leave, I give them my card and I say, if you need shoes or a phone or housing or a great big sandwich, just let me know, kind of thing, and then get back here. Make good on the sandwich and we'll talk, And so that's how it starts sometimes, in that connection. But we know that 58% of the kids that are age out of care will end up in entrenched addictions and homelessness within 3 to 5 years. That's a statistic that Aunt Leah's and SFU put together, and it's a pretty reliable statistic. But what's sad is it doesn't take into account how many kids walked out of care. They're the ones that are really at risk, because most of the kids I work with, at 16 or 17, they were a nightmare for their social worker. They're like full, trauma goes a long way with these kids. It happens in utero, FASD, ADHD, scattered minds, Dr. Gabor Mate, that kind of, background. We're starting to understand that it's not even at birth. It happens when these kids are in utero. And then what happens in their first few years of life, no matter, even if it's a divorce, it's trauma. These kids don't understand it's all about them. They did something wrong, why daddy left, right? But some of them are extreme trauma. I've got a client that he was taught by his father to dismember other gang members on the kitchen floor, with tarps and stuff. And this kid was like, he couldn't even talk. He didn't have a voice, right? He was like so in there. And he just phoned me about 2 weeks ago, and he's dancing all over the place. You can hear him yelling and screaming. He'd got into UBC creative writing, and this is a kid that couldn't even look up. So trauma-informed therapy really, but the first thing we have to do is recognize their pain. This is the big problem we've had with now doctors of BC and us are talking the same language. But if they couldn't x-ray it, if they couldn't scan it, if they couldn't see it on an MRI, it didn't exist. And asking a doctor to provide safe supply while the kid is in therapy so that they are not triggered and use and die, and then taper them down with Suboxone at the end of the 4 month of treatment, or 5 months, whatever it takes, we see about a 50% success rate with that. And we're just kind of experimenting with it because it hasn't really been legal for too long. We may have been experimenting for a little longer than we were allowed, but these kids' lives are at stake. I'm perfectly willing to take that risk with a kid, and if the doctor's willing. But now the doctors are more than willing. They're understanding that, that they need to be part of the solution, because we can't solve it and they can't solve it. We have to be able to do this together. So in our talks with the doctors of BC, and also with the ministry federally and provincially with mental health and addictions, we've all talked about, wouldn't it be nice to have a center of excellence for trauma and therapy and trauma-informed recovery, so that we could actually teach it properly and guide people. We have a manual that we've just about finished that I've produced in order to train my team, because even though they come with a master's degree, that's the minimum they have to work for us, a lot of them haven't had a lot of trauma work, especially if they graduated a while ago. And a lot of the trauma work that's current is, if you look at it from a therapeutic perspective, it is enabling. It's not really empowering. And that's what we really want to see happen. So when we have these kids in therapy, what we're trying to do is get them to that place where they really, are safe, first through self-regulation. they don't know. I've had a psychiatrist that was prescribing Risperidol and Seroquel. The kid gained 100 pounds and started to lactate. This is a little hockey player. It's pretty embarrassing to start lactating in your gym thing. And nobody even asked him. First thing I noticed is he had a Monster drink and another one in his backpack. And I said, how many of those do you have a day? And he says, 4 or 5 before lunch. Well, I had half of one and almost went into psychosis. I mean, have you ever had a Red Bull? Well, these things are this big, and the kid's drinking them, and nobody even asked. He stopped that, and I had him off Risperidol through with his doctor, of course, and right off all that stuff within a month, and within a year he was back almost normal again, and but nobody had asked him. So how could that be considered trauma-informed? That's trauma-inducing. We didn't even ask him. We have to have more care there. And this is what we brought up with both the federal and provincial ministries, that when one of our therapists takes a kid into Royal Columbia and we sit there while they're in psychosis for 6 hours, trying to keep them in that room, in that waiting room. And that's a pretty scary place, not even in psychosis. If you're in psychosis, it's really a scary place. And we sit there and we finally get them through the doors. And we get home, we pass out because we've been up all night, and we get a phone call from the kid a half an hour later saying they're already out. So there's some things in the system that really need to be addressed. It's not, keeping them in too long. I know there was talk about, having a bill that would keep them in, but the Mental Health Act is perfectly capable of doing that. And even more as well, if it's used properly. And this is where the doctors of BC and the college has to come in and back up the doctors that are afraid to use it or who are afraid to provide safe supply because they perceive consequences. I mean, some doctors are never going to do it. Their attitude is, I'm not a dealer. I'm not a drug dealer. I'm not going to do it. And they miss the point entirely. What we're trying to do is they wouldn't hesitate if that kid came into the hospital with a broken shoulder. They'd give him a shot right away, and then they'd do the surgery, and then they give him the OxyContin, and then they'd have to be dealing with him a year later when he's down on Hastings Street because he couldn't stop. So what we're saying is there's a lot of tools out there, but if they're not being used, then why develop new ones? And so this year we've got to this place with this team, and we're expecting to see 600 youth in our therapy program. We had 24 youth go through our Intro to Cook program last year, and 20 of them are working. And these were some of the kids that nobody thought would even be able to take the course. But trauma-informed therapy is when we find that youth's potential. They come in with a briefcase under their arm, a file folder with their problems. They're experts in their own problems, but they don't know what their own potential is. And when we can find that with them, and then say in 5 years, if you thought you could be a cook, where could you be in 5 years? And when they can see that, then they begin to move away from the problems that are anchored in that current situation. So it's really a logical approach. It's not like magic at all, but it's not as exciting as listening to them tell you about their abuse and stuff like that. Like a lot of therapists, it's an entertainment thing almost. The kids just go there and rent someone for an hour and just talk. We make them work. We want to see if they're going to change we'll provide the food, you change your diet. You can't live at 7-Eleven or dine at 7-Eleven and think it's going to be okay. Evolution, 1 million years of evolution never predicted 7-Eleven. Our pancreas would have never put up with it, right? And but that's what we've done. We've paved over Mother Nature that self-regulated us. And now we're expecting these kids to self-regulate, and nobody's ever taught them. They were raised by the state in 15 foster homes. That's the average 15 placements that we deal with. Now, it's not always like that. There's some great foster homes out there. I was a foster dad for a long time, and I think I provided a really good service for some really haywire kids, but they're still kids, right? And but I think that there are a lot of foster situations that are less than good and some that are criminal. And when you go through 15 homes, you've probably had all of it. So the trauma wasn't just at birth or in utero or when they were brought into care. It continues when they age out at 19. Thank God that's changing, because my kids are 42 and they're phoning me on a regular basis. Dad, what do I do here? I'm going, I don't know. I can't phone my dad. He's gone, right? It's like, nobody knows these problems. But these kids don't know that nobody knows, and they think it's only them that don't know. And so they're lost in this, they don't get the social contract. So we're there almost providing reparenting as well as therapy, life skills, and work skills. Because if they can't make it to that first rung on the ladder, they're not going to make it. You know, and the first rung on the ladder is their first job, successful at recovery, going to college with the waiver program, or all of these things. They're there for them. The tools are there. But we have to make sure the kids have access to them. And a lot of what we do is just run interference. We just, you know, you need to, first of all, you need to register with Fraser Health to get into Surrey Mental Health. But let's take you to start with, so because you've been some self-injury will do, or whatever, because Fraser Health isn't communicating with itself. We have to basically get these kids from place to place. You get a kid sitting in front of you that's got income assistance, doesn't have it, couch surfing, doesn't have a bank account, lost his ID, he's hungry. Where do you start? At the beginning. Anyway, I see the red lights flashing. I don't want to see what happens when that stops.
Nothing, I assure you. Thanks, Tom.
Okay.
We'll pass it over to Jason, and we go ahead.
All right, thank you. I'm still curious, what exactly is the trauma-informed toilet paper made out of, and where do I get it?
Very special old growth forest.
Okay. I wanted to start off with just recognizing that we have the opportunity to live and provide service on the traditional and unceded territories of the Coast Salish and Nklakatma nations, and very grateful to have that opportunity. A big piece of what I'm going to be talking about is more to do with our substance use continuum, although PCRS is an agency that's provided more than 35 years of service throughout the Fraser Valley. I think we started out with residential programs, expanded into housing, expanded into some programs with Work BC, helping folks find employment. We are predominantly youth-led, so there's a ton of different programs that we provide, reaching out to people who are newly landed immigrants, and helping them to connect to community, to alternate schools, a couple of different alternate schools. We have youth hubs where they can connect in and just have a safe space to be, and also be able to connect with the services that are appropriate to them. But I think that what I want to start with is we led a forum with Fraser Health where we were just asking some of the youth with lived or living experience about what they see as a good way forward in moving in recovery. And why we started with that was to gain the insight of the people who are going to adopt the service, because the only good solution would be the one that's chosen, in my perspective. So some of the key pieces that came out of that I've put into the slides, but some of them are barriers that they've experienced in accessing services. So for one of the youth, and this was a group of 8 youth, this is still ongoing. This is a forum that started Monday and will be going until sometime next week. Barriers to accessing services. One of the youth that was presenting at our forum had the experience where the individual that they were trying to connect with never had followed up with them. They had made initial contact, and there was no follow-up contact from that. A lot of them identified with the stigma associated with mental health and substance use and being able to walk through the door. For them, a big part of this was the accessibility and availability of information about what was even available to them without having to go to a door where they're identified as somebody who's being at risk of substance use or demonstrated as having mental health concerns, which by itself, walking through the door is a big enough thing, let alone if you're also given a sticker or something like that that identifies you as a subset of the community in some way. The choices around what's suitable for them often weren't available. They'd be assigned a counselor after enduring some type of a wait list, and the choice, if that counselor wasn't a good fit, to choose a different counselor just wasn't made available to them. The lack of understanding of professionals before offering different solutions. So they would walk in the door, and without listening or fully hearing and comprehending what they perceive the the solution to be or what they perceived the problem to be, different resources were handed out and kind of almost at rote. And in that, I think that Stephen Miller with the feedback-informed therapy recognizes that the probability of success comes at meeting them where they're at with what they're looking to change. Conversely, what was helpful to them was access to long-term service, so somebody that they could stay with for a longer period of time. One of the stories with, again, a barrier was that they wouldn't necessarily be notified if they were going to have somebody that would change over as staff, so their social worker or their counselor might change jobs and then they would be just assigned a new one. Not necessarily having that prospect of closure, but also not having that continuity of relationship. The developing the personal consistencies in routines, having people that meet you where you're at, so if you're not willing or ready to make a change to substance use, being able to identify what they would welcome, finding hobbies or healthy activities, support focusing on the whole person, so brain, body, their mind, their spirit, and not just treating substance use in a vacuum. Developing long-term relationships with family, friends, just people who offer unconditional support. Those outside connections that can often be lost because of substance use, and a part of it that I might speak to with what I would see as being the ongoing repercussions of things like prohibition from the past, carrying forward to mentalities where it's treated as this person should be separated from community rather than connected. Having somebody who can either hold hope for them for the future or point them to a direction where they might have hope, and opportunities to connect with oneself, one's culture, and the people that belong to that. So along with this, part of what we were seeing coming out of that conversation as a potential way forward was kind of a threefold task, and all carrying some of the same elements. So destigmatization, and I'm going to borrow a little bit from Len Pierre. He's an educator inside of Fraser Health, and if you haven't had the opportunity to either listen to him speak live or some of his videos online, he does an excellent job of presenting a decolonizing perspective on substance use. And he speaks to stigma as holding space because of four essential pieces. The lack of context, misinformation, discriminatory language, and bad policy. While I'm not in a position necessarily to speak from the Indigenous perspective, I think that a lot of that holds true inside of anybody who's experiencing substance misuse. The lack of context doesn't take into account those early years that we were talking about, the ACEs that Tom mentioned, or the developmental factors that even happen in utero that led them to a point where that was a viable choice. The misinformation of what substance use actually entails, what causes it to continue, discriminatory language, using non-person first language like calling somebody a user or an addict rather than a person who uses substances. So he speaks to that as using the person first language, bad policy. And in this, he was referencing the carryover that we experienced from prohibition or other policies that Indigenous people had endured that don't put the person at the center of the need or the service. I think somebody, I can't remember where I got the quote from, so I'm going to quote it uncited, but that in a war on drugs, the drug can't pick up a gun and start fighting, that we're actually fighting against the people that are most affected by it. So alongside of this, dealing with destigmatizing, moving towards upstream prevention where the person has a viable alternative to move away from substance use before it starts, and developing viable alternatives. And to this, from our perspective with our programs in Traverse, our inpatient bed-based program, our day, evening, and weekend for youth day treatment program, our outreach counseling group referred to as ASTRA. It's an acronym. Don't quote me on what it stands for right now. I probably won't remember off the top of my head, but and our prevention team, all of which operate within the Fraser Valley, anywhere from Surrey to Chilliwack, and in that, really carrying a focus on developing those viable alternatives in a sense of belonging, mastery, independence, generosity, because from the perspective that we hold, the opposite of addiction is connection. So a bit of what we're doing, and I already referenced this in part, our Traverse program, we try and approach that connection to relationship as not just a relationship to other individuals and community, but individuals connecting with family, connecting with nature, connecting with themselves, connecting with the things and the things in life that make life more living. It's commonly referred to as social capital in some sense, but relationship is a different way that we frame that. Our DEWE program carries a similar focus. We combine recreational activities with core therapeutic programming. So the recreation is built with the intention of them challenging themselves to step into something, to re-explore the options to move forward in life. Recovery seen as reclaiming some aspect of self that was lost. And then I'll reference our substance use prevention program, which is largely based on the model out of Iceland, where they saw a sustained period of 10 years with steady reductions in problematic substance use in the youth in their community. And when they cite that, they also cite that as opposed to just because of some of the natures of the geography, what they would often see was that the way that most adolescents would use, they would see problem consumption of alcohol as more something where they would drink in vast quantities to the point of blackout rather than drinking what we would see as recreationally here. So in that, and I think I might be able to close with a couple minutes extra so you can take that back from your lunch. What the youth were still hoping for was, and this is what I'll close with, what didn't seem to exist in the service continuum as they saw it was an atmosphere where they could walk into a home-like environment, where they could access the services as they saw fit. So it not being a one-size-fits-all, we're walking into this is the structure of the program, but I can enter at the level that I need to. That the care and support was presented in a non-judgmental or responsible way. One of them specifically citing that in their experience, more often than not, they could hold their stuff together for the 9 to 5 that most people are working. It's those other hours of the night where the stuff creeps up on you and you don't have the resources available to you to cope. So wanting somebody who could offer that level of responsibility and care at more of an expert level in the hours where they felt most vulnerable, which is often for them the wee hours of the evening. Access to culture, community, friends, rather than having to separate from their world. So being able to treatment as it's traditionally offered is something of an island from the rest of your life. And for some, that is a valuable opportunity to be able to separate away. And for some, the thought of being able to or having to leave home and community just represents something that they might not be willing to take. And one of the last piece was just a choice in how they can engage and the options that are available to them to engage. So if I don't like going to 12-step meetings, I don't want to have to go to 12-step meetings in order to facilitate my recovery, although they do present a very valuable option. Having the alternative of smart recovery or some other therapeutic means to be able to engage and choose as you're walking through this type of resource were all something that they deemed as appropriate. And I'll close by just saying thank you for the opportunity to speak and meet with all of you. And I look forward to hearing what results come of all these meetings that you guys get to sit in.
Okay, thank you both. We'll switch now to questions. Go ahead, Susie.
Thank you. Thank you to both of you for the work you do for our kids at risk. I, too, was a foster parent for many years and got some of those kids that had already been through 15 other places. So it's a tough role. So when you think about the work that's going on in BC writ large, so your focus is really in some of our larger communities right now, but we all know that there are kids that need throughout the province. When you think of BC writ large, are you able to put it in sort of somewhere relative to the rest of Canada? Are we doing okay? Are we doing better? Are we doing worse? How are we doing in this area? And in terms of our platform to move forward from?
I think that we have a lot of integral pieces that are necessary at the front of things like opioid.
I think you're going to have to speak a little louder to the mic.
There's people listening.
I can hear you, but the mic may not be able to.
We want to be able to hear you.
Inside of Fraser Health, I think that there's a lot of pieces. Well, inside of all of the health authorities, I think that there's a lot of the necessary pieces that are available for moving forward. Things like there are new food program to do outreach to people who are experiencing some sort of an overdose. There are other continuums of care like the youth concurrent disorder therapy programs, the access to opioid agonist treatments. I think from what I gather of this, from what they were saying, to also have what's available in community, what they're coming back to in community to be a place of connection, something where they can perceive it as being a viable alternative. That's where they seem to be commenting on what was missing.
Our focus is basically Metro Vancouver at this point, although there has been some talk with the Ministry of Mental Health and Addiction to help with the module system that they're thinking about, because I know that there's especially when we talked to doctors of BC, we saw that some of them were quite concerned because they might only have one or two therapists in town and they don't think that they're the right ones for the job, or how do I know? And, so that's something we might be able to help with provincially. But this time it's, we're dealing with probably about 10% of the population that needs us, and we're paddling as fast as we can. We try not to have a waiting list. That's the real thing with these kids is if you say 4 months, it's another life, right? So we try and have it where we get to them within a couple of weeks if it's a normal kind of referral, or immediately if it's an emergency.
Sonia.
Thanks, Nikki. Thank you both for the presentation. One of the themes that keeps coming up is the belonging piece and the need for connection to community. And Tom, when you say 58% of kids who age out of care end up in entrenched homelessness, to me that's a measure of, we have a systemic problem here, and
yes.
I think that us as legislators really need to sit with that figure and recognize there are provincially funded systems that are creating outcomes that really are not in the benefit of young people and children. In terms of the last slide here, what the youth still hope to see developed, and I know that this is something that we have a network, the Cowichan Health Network, advocating for a very similar thing: home-like, inclusive environments, a place for youth to be, and that really seems to be lacking, certainly in a lot of, I think, smaller communities. But could you go into a little bit more detail about what would be needed to achieve meeting these needs that the young people are identifying?
I think from what I would hold from my perspective, it could be approached from two different lenses. One, an aspect of recovery, something to the effect of social detox and stabilization that can allow for a youth to have a period of time, whether it be a month or months, a short period of time, to be able to step away from a certain community, engage in something that would be supportive of their recovery, that they could connect back to, especially after they left that specific facility. That it's not something contingent on just being present in that space for them to be a participant of that thing that they perceived as being helpful. The other side of things would be so our prevention program is widely aimed at developing social resources, so connecting them to supportive adults, connecting them to different levels of support that they're needing to be able to maintain just being present at school and getting through that, let alone dealing with the different aspects of life. But having something that is solely dedicated to building that social capital of the individual seems to be an important piece for a lot of these kids that we see moving forward. And many of them, so we have a camp that's attached to it, and many of them will come back as peer leaders to give back as an opportunity to show how they've moved forward and how much they've appreciated having that connection.
Yeah, I think from my perspective, what I see missing is, the waiver program to get kids from care into college and stuff is amazing. The AYA program to support them, and I think there still needs to be some alignment between the two things, because I've had kids that qualify for the waiver program, but they walked out of care, so they don't qualify for the AYA program. So if they want to try and go to a university and look for a job at the same time and stay on welfare, its system needs to be aligned better that way. But there, a lot of these kids that we work with, and the majority, we see this is the average kid that's aged out. Trauma around 3 to 5, identified as the trauma personally, took it into themselves, went through all these foster care situations, some of them good, some of them bad, some of them criminal, and then aging out and having grade 8 and no work experience, no life skills. They don't know how to cook, they don't know how to clean. There's no, they're allowed $375 towards housing in the Lower Mainland. I know it's been bumped up a little bit, but but we're seeing that the whole thing is inversed in their world, and so it's a psychology we're trying to deal with. I know in my family they always wanted someone to graduate from university and get the degree. That would be a lot of these families with generational poverty or colonial trauma all the way down the line. They look at a PWD as, wouldn't that be nice if someone from the family got a PWD? It's the ceiling. It's not the safety net. I mean, it's an amazing safety net, but it's not the ceiling. And these kids that's their view. So we've patched together things to try and make the runway, we call it the proverbial runway. We have 3 months of training, 4 months of therapy. That's a really short runway if you've been, had your whole 20 years of life messed around with. So we have a grant from the Ministry of Poverty Reduction, and it's for a job placement kind of thing. So we can hire them at the end of the training program and add another 4 months to the runway, and some more life skills, and fire them a few more times. They have to come back the next day, of course, but they have to learn what firing is. I mean, they haven't been raised in a family, so they don't get the social contract, and they'll do the darndest things. Right in class, we had a kid spark up a big joint, and I'm stressed. I'm stressed. Well, that wouldn't last very long at the white spot. You'd probably be tossed out the back door. So recognizing their pain, that they're desperately trying to self-regulate with a drug, not judging them for it, but then moving them towards a functional way to self-regulate. That's what therapy is. That's what trauma-informed therapy is. Not saying, what's wrong with you? That's what they're waiting for, And that's why a lot of them don't have a voice. But if we can look at them and say, because, what I see happening in a hospital, if you get your broken shoulder, you get all the treatment you need. But if your family and your placements in your life broke your spirit, you get nothing. And they're just as legitimately in pain as the person with a broken shoulder. And it's totally healable if we look at it that way. You know, sometimes it isn't if we've got concurrent stuff going on and, FASD or ADHD that's really extreme, OCD. These are things that really can complicate the situation. But, we've seen kids successfully get something out of therapy with even though extreme difficulties, and the work experience gets them the basic job, and they're perfectly happy with it. Probably will be for life. I don't want to learn. This is it. I love vegetables and chopping them up is my world. That's okay for that person. A lot of kids want to use that just as a launch pad to get into a regular life. They'll probably be running for office in 20 years, right? They're normal people. They just have had nobody there with them when they started out, and so that they need that now. And provincially, most of these kids end up down here anyway. Even same as, do you want to spend the winter homeless in Winnipeg? Or would you rather come to the land of, free rent and free food and free drugs? And, that's not true, but that's what they hear on the streets of Winnipeg at 35 below, right? So, so we're dealing with not just the 1,000 that age out in BC, that age out of care every year, and the 1,000 that end up on the streets. We're also dealing with all these people from all across Canada that come here because they're free and independent. So I think a lot of the services federally have to be focused where they are so that we don't end up with an overwhelming kind of problem here.
Pam, and then Shirley. Go ahead, Pam.
Thank you so much. A couple things. What's your relationship like with the schools? Because we spoke of alternate education and all of that, and I know that the schools are overwhelmed with, very high numbers of kids that are on the edge. There's no question. And COVID only accentuated those numbers. And if you could change something tomorrow with respect to the relationship with schools, what would it be?
I think having a system where the school counselors can kind of tap out and bring in a more specialized counselor to deal with the situation. They feel like I don't think they have the resources in their own community or know about them, what they can draw on. So a lot of times they try and just do what they can do. And a school counselor isn't necessarily who you'd want to be doing trauma-informed therapy with a kid. They really, they're looking at how to get them through school. And, we have to look at the 5-year plan to get them on a life course that is functional, So that kind of a proper referral system. We're just setting up this referral system with the hospitals. There's the talk about a new number coming out instead of 911 for mental health issues, that kind of future where that can be more focused. A lot of these kids they'll ask for help between 15 and 25, usually about 15 to 19, 20. They'll ask for help because they realize they're not doing well. They're in a little wee box in the basement in Surrey. They have no money, they have no phone, they have no Wi-Fi, they have nothing. They have a microwave and a hot plate maybe. And you're expecting that kid to survive. It's not going to be real. So developing a system that, where not just the teachers can refer, but the ambulance drivers, the fire people, the police. So there's a consistent kind of approach to this so that when you need a therapist, a properly trained therapist shows up and not trying to find one for $150 an hour for your kid on the internet, which is, you might do well, you might not.
Thank you.
Shirley, go ahead.
Well, thank you very much, both of you, for your presentations. We appreciate it. And I read Dan's story through his mother's eyes, and it was pretty hard to read in terms of the painful journey that they were on. It's one of the things we're hearing is that there doesn't seem to be enough avenues for engagement and discussion with people with lived experience and sort of on the front lines. We've heard that in the last 3 days, especially because groups that have been here have said we're so happy to be able to participate. And, yesterday Vandu was a really good example of that, they were more than happy to be here. So maybe talk a little bit about how do we create a more inclusive way of creating policy and driving decision making, because I can tell you I am no expert in this field at all, and you are experts because of your lived experience, the work that you do every single day. I mean, we shouldn't be sitting in isolation creating policy and thinking about how we change the system for the better. So what are the barriers to your inclusion in those discussions, or are there, or what do we do to be more intentional about hearing from people with lived experience?
With our experience in getting youth feedback, there are some programs, and going to your question as well, our prevention program is school-based, and the receptivity is largely based on administration as to how we can present materials and raise awareness. But they do an excellent job of collecting youth to bring them together to offer a voice. And these are youth who are identified as either at risk or are aware of somebody who's at risk. They're youth in school who just would be seen as benefiting the support. Our ASTRA program, our substance use continuum, I should say, is also seeking to develop a panel of youth that would be able to contribute their voice to different issues. But having that opportunity where they're able to be present and able to give back, because in my experience, I was walking through a parking lot behind a building to get into one of the resources that we had. It's close to Encompass and Langley, and that's often a space where there will be a large gathering of people who are homeless. And in that space, I've had more than one person come up and say offer me a piece of pizza. The people that are out there are generous and looking for opportunities to give back. Creating a venue where they can have their voices heard seems to be the biggest piece.
We try and hire staff that have had life experience. I've had lived experience myself. I'm a residential school survivor, and I was an addict in the 60s, way back there. And I can't even remember how long I've been clean, but I've been clean since I'm 20 and I'm 71, so a while, And but it was I didn't see any opportunities or any, back then it was jail, or there was no social workers that would help you. They'd send you home, and the problem at home was what got you on the street to start with, right? But, a lot of the decisions we see being made, like I spoke at length with both federal and provincial governments about safe supply, not legalizing a toxic supply. And, it's like, what do we have right now? We have a legalized toxic supply. We're moving towards safe supply. Nobody should be arrested. It's a medical problem. I'm happy for all of it, but I think, it should have happened at the same time, so that, people didn't think that it's now safe to use because it's legal. The people that are really getting it now, they may have had trauma in their life, but they were able to muscle themselves over it. And now they're that young guy on the construction site, and he crushes his hand, and he goes to the doctor, and the doctor says, it doesn't do the ACE score, but, says you look like a pretty reliable young guy. Here's your, whatever, your painkiller, opiate. And then in 3 months after the surgery, and he's gone the course, and he asks for another prescription, and he's refused. He buys everyone's used prescription that didn't have trauma, that crushed their hand on the job site, and then eventually he's on Hastings Street buying active supply. They're the ones that are dying now. It's not the hardcore addict in East Vancouver. They got shooting galleries and nurses and guys on bikes and Narcan kits everywhere. It's the kid that, if he tells his boss or his family he's using, he's going to get fired or thrown out of the home, and he's the one that's going to die because there's still shame and stigma involved there. That's an issue that you can see that not a lot of people with lived experience made that decision. I mean, it's important that it shouldn't be illegal. It should be, like in Portugal, a medical problem rather than a police problem, because the police have never been good at it, you know. It's a job they don't want either, really. I mean, it's like, you know, the whole end of it is just, you know, when we can deal with a kid for about $2,500, provide that 4 months or therapy and maybe a little bit of intervention in that. Once they've turned the corner 5 years later and they're a hardcore addict in downtown, it's millions of dollars. You got fire trucks and ambulances and police and prisons and hospitals, and it's just a complex problem that costs a fortune, and it's almost impossible to turn someone around at that point, because you're not just dealing with the addiction, you're dealing with all the rituals that come along with the addiction. When we do the trauma work with someone and we help them get to the place where they're ready to go on Suboxone and get off the drug completely, it's the rituals that are going to trip them up. And those rituals can be there for the rest of your life if they're not identified. I mean, I go in for a blood test now, it's about 51 years, right? And I put my arm out, and the nurse pulls out the needle, and I'm sure my eyes go, ooh, my brain, something happens, right? I'm going, and I know when I'm going to my brain, you're a trained therapist, settle down, kind of thing. But, it's body memory. There's a whole bunch of stuff taking place there. And if you don't identify with those triggers, it's like walking around with one round left in your revolver and you don't even know it, and you're doing this. So it really is important to look at it holistically. And so I'm glad that, we have Creekside, not Creekside. Crosstown Clinic, I should say. It's one of the few places where you can work with an addictions doctor to get a prescription. There should be one of those in every community. And they're trying to do this, but it's hard to, because, asking them to go cold turkey and asking them to, abstinence and submit to a higher power, and you're an addict for the rest of your life, they don't buy it. The average young person thinks you got the problem. And technically we do, because we got our blinders on and our prejudices in place, and pull yourself up. I did it. Why can't you do it? What I had to do to go through my trauma was, I don't recommend for anyone, 3 years on top of a mountain, 17 miles from a road. You can rage all you want up there. No service, you can't call your dealer. There's nothing, right? So that's a pretty drastic way to do it. We see most of the kids achieve a recovery they're comfortable with, which is what we're talking about, in 4 months to 5 months without in treatment, in care at all. If they know they've got a safe supply while they're doing the work that's going to trigger them, the work will trigger them, because they have to face what got them there. That's the way we need to go, and making it legal so they don't get a criminal record and all that kind of stuff is important too. But I think we need to go way more upstream and deal with these kids when the first time they say, I got, in school or in Aunt Leah's, or we work in PCRS programs, we have 3 programs our therapists are in, that we provide this service with 17 partners, so that we're right where the kids are. When they first say, look, I'm having, the youth worker there, or the Aunt Leah's can say, why don't you go see one of the Dan's Legacy counselors? So what we're doing is empowering each other as organizations, rather than us becoming an expert in housing. These guys already are. We focus on the therapy and this other stuff. They focus on that. And we are able to meet the needs of these kids. But that's what's really needed, is everyone kind of working together rather than in silos, right? You've probably heard a lot of that in the last 3 days.
So I'm going to jump in with the final questions here. First of all, thanks for what you provided on the work you do. I was really intrigued by a couple things. We've been learning a lot about the kind of treatment system that we have, and the need for just kind of a more, I don't know if it's regulated or standardized or something that has standards when it comes to how we respond. And you mentioned a Center for Excellence for Trauma-Informed Counseling, and that being, yeah. And recovery, yes. and that being something that we may be able to house through the work you're doing. And I want to know a little bit more about that, and it's tied to kind of my second question, which we were just learning how relentless the drug supply is now in terms of its increasing toxicity, and that, like, drive from the illegal market to get the most potency in the smallest amount, and that how hard it is to just kind of get people through, and the relapse rate, and the fact that the retention on the OAT programs sometimes don't stay, and all the kind of things associated with that. So I'm just really curious how you are both doing in terms of relapse and retention on OAT and the trauma-informed approach, and whether that shows like a sign of you being better than the average, or what the things that we're seeing with just the toxicity and addiction of the drug supply.
I can go.
You want to start off with your center?
Sure. Well, I mean, this is a dream of mine. A lot of my dreams turn into nightmares. But I really believe that, we really need to standardize an approach. The doctors feel that, the ministries feel that, everyone feels that, because it doesn't mean anything anymore to say a trauma-informed approach unless you're backed up by what that really means. And a trauma-informed recovery, there's not a lot of people talking about it, because up to about a year ago, until Crosstown Clinic, is a doctor would have to kind of write your prescription on the side, and they're risking an awful lot. And why should they? I wouldn't, I have, but I can see it from their perspective that they don't want to risk everything on helping someone when they might lose their right to practice, right? So I think the government has to really focus on talking to the college and to the insurance companies that insure the doctors, and to the doctors, so that, they are given permission to be doctors. They feel like their hands are tied right now. And a lot of the oats thing and stuff that we're talking about, these kids are in agony, and you want to put them on Suboxone so they can't deal with their pain. That's not, or methadone, which is the worst drug of all. It's the hardest one to stop later on in life when you do want to stop. If they want fentanyl, give them fentanyl. If they want heroin, give them, synthetic, heroin. This stuff is clean. They're not going to die from it if it's given out properly. You test them. You make sure if they're in this contract that they're not, it's not here, have some drugs. It's very tied to performance and doing the work in therapy. And if they don't do the work, you phone the doctor and say it's done. The therapist calls it off, because we're not about to be maneuvered by this. How do you know when an addict is lying, right? Their lips are moving, right? They have to be able to create this thing to get through life, so that I will give them a gift card and you'll give them housing, and they have to. I did it. I was expert at it. I could walk into a place and just look at, geez, we got sleeping bags, hiking boots over there, and I'd walk out with that stuff, right? And I'd say whatever was necessary. Oh yeah, I'm going to work tomorrow. You're an addict. You have to do that to survive. You can't judge them for being you can say, wow, if you had some skill sets besides doing drugs, you'd be quite entrepreneurial. You could really have something going here. So, again, strength oriented, go towards their, I was like a basket case. They put me in Ocala at 16 because it was the safest place for me and for the community. But I had no options. And I didn't know what was wrong with me. Most of my memories had been, I complained to the family doctor and they sent me to Riverview and ECT and ice water baths, because obviously I was psychotic, because priests and brothers don't do that in the 1950s. Right? So not being believed, not being understood is the key thing. That's what the part where, when they believe that you get it, that you understand them, not that you an ex-drug addict and you get it. I hate to have to see all these people have to go and get addicted and off drugs again just so they got lived experience, right? But anybody who cares can get it. It doesn't take rocket science, but you have to care. If it's just a contract, then it's a whole different thing, right? So, but, I know most of the workers that I meet with PCRS, with Aunt Leah's, with our people, we're all a little insane. We really care. We're really trying to do it. Impossible odds, burnout super high, and yet, we're doing it, right?
I won't speak to the center because that's your dream, and I can attest to just being a little bit insane. But the piece that we see when we're successful, and I don't want to say that we're more successful than other community partners because there's a lot of people doing a lot of really good work. The piece that we're seeing, though, when we are successful is that the youth will engage for a longer period of time because they see this as a viable alternative to their use. And that is with the pain of coping through trauma, that is with having other mental health diagnoses that prohibit them from thinking that they can function in the world as a part of the normal social contract. And I think that that's where we do most of our good work, is when we can bend their perception of what they actually need to do in that social contract to be a part of things in a meaningful way. Because oftentimes it can be perceived as something that's very narrow. Yeah.
I mean, I think that what we can do is keep up this kind of dialogue so that there's a way to talk to both sides. You know, I mean, we're not political. I'll take money from anyone except the Hells Angels, right? And I've had them try, right? You know, I actually got one of their daughters off the street, you know, and he comes in with a big roll of cash, and I'm like, whoa, you know, I know where that came from. But, you know, they don't want their kids in this thing either, right? And but there really needs to be more of a dialogue between the federal and provincial governments. You know, we have a training program that was funded by the ITA, the Industrial Training Authority, and we were notified the federal government didn't transfer the money to the provincial government. The provincial government didn't get it to the Ministry of Advanced Education. The Ministry of Education didn't get the funds, and 19 programs like us got shut down around the province. And we just kept going. We just, you know, let's just keep, you know, it's like running across a lily pad, a pond on the lily pads. It works, but you can't stop, right? So we're trying to find funding to put toward this program that 24 kids that were basically considered level 3, like, don't worry about them, just, you know, entertain them, are working and like their jobs. Out of 24, 20 are. And we want to do that. That's an intro to cook. We want to develop that into warehousing, commercial driving, and bike mechanics like we used to do at Sanctuary Foundation, because they're things kids want, and they're quick, portable, kind of a job where you got a diploma on the wall, not a degree, but a diploma, and you're being hired because you trained a little bit. So the kids feel like they're empowered rather than, well, you know, a program that gives them job skills where they practice getting a minimum wage job so they can keep the minimum wage job after they got it. That's not going to hold them, right? You know, I've probably trained 1,000 bike mechanics in my career. Not me, but people who know about bike mechanics. But, you know, and they're all not bike mechanics, but that was the first job. The ones that are bike addicts are still bike mechanics, but the ones that used it to get their first job, they might be running an arena now where they started out doing that and sharpening skates, and then, you know, up to there's many ways to get there, but they have to be a place to start. And what we see is that gap between, you know, where they are and where they can start, that first rung on the ladder, that has to be addressed, right? And we don't really see that. The programs out there like PCRS and us, we see it, but not necessarily the funders, right? People who are writing the checks, right?
Thank you so much. On behalf of the committee, I just want to thank you for, it was such an engaging hour to learn about not only your vision and dreams for what could be better, but also the work that you do every day for people. So just want to thank you for that. I think we all learned a lot, and we'll definitely be in touch if we have more questions. So thanks for your time.
Right on. Thank you.
Yeah.
Thank you.
I also want to say that Lynn Pierre, the reference YouTube, yes, is in your presentation.
Yeah, Lynn here, I've referenced it directly, yeah.
Right, and there's a link directly to the YouTube.
There should be, yeah.
Yeah, there is, so thank you.
Thank you so much. Yeah.
Okay, so we're going to recess until 1. Enjoy your lunch. Excuse me. So my name's Nikki Sharma. I'm the MLA for Vancouver Hastings, and I just want to welcome you on behalf of the committee. Maybe we'll do a quick introduction of everybody that's at the table, and then I'll read out all of your names, or maybe you want to introduce yourself, and then we'll get going. Go ahead.
Thanks, Nikki. I'm Shirley Bond. I'm the MLA for Prince George Valemount, and I'm the Deputy Chair.
I'm Trevor Halford, MLA for Surrey White Rock.
Dan Davies, I'm the MLA for Peace River North up in Fort St. John.
Sonia Fresno, MLA for Cowichan Valley.
I'm Susie Chant. I'm the MLA from North Vancouver Seymour.
And I'm Ronnery Leonard. I'm from Vancouver Island, beautiful Comox Valley, Courtney Comox.
Pam Alexis, the MLA for Abbotsford and Mission.
Okay, we're so grateful that all of you joined us today, and we're really looking forward to learning from you. So I'm going to read all of the names that I see here for the Hansard record, and I apologize if I've mispronounced. Oh, there we go. So we have Caitlin Shane from Pivot Legal Society, Brian O'Donnell, Garth Mullins, Jeff Ludden, Laura Shaver, Caitlin. Sorry, Ludden? Loudon, thank you. Coward Kalpas and Ryan Mado. So welcome, and that's from the BC Association of People for People on Opioid Maintenance. So we will have, I think it was 15 minutes for each presentation, but please tell us what you want us to hear, and then we'll leave the rest of the time for questions and answers. So I guess we'll start. Caitlin, did you want to go first, or?
Do you want to start first, Garth?
Okay, we'll start on that side then. Okay. Sure.
Hey, I'm Garth Mullins. I'm on the board of the British Columbia Association of People on Opioid Maintenance, which is who you see before you: Laura Shaver, Ryan Maddow, Jeff Loudon, Ryan O'Donnell, Howard Kalpas, sorry. And we're elected by our membership to run the organization and come before you. BCAPOM is what we are short for, and we were formed in 1999, or 98. We're still trying to figure out the exact year, but we've been at this for a long time. Our mandate has been the same. We've been fighting to reform the methadone system. I've been in this group for about 10 years, and I've been on methadone myself for 20 years. And the people who came before me opened up the system a little bit so that people like me could also get on methadone. It used to be even more restrictive. But since we've been active, we've seen lots of other medications come online that are prescribed in British Columbia, like Suboxone, like Dilaudid, hydromorphone, Cadian, that's right, slow-release oral morphine, fentanyl. And these are all trying to do the same thing. They're all trying to replace or reduce the amount of the deadly illicit drug supply that we have to rely on. Some of us are old enough to have lived through 2 overdose crises, 2 officially declared overdose crises, including the one in the 1990s. So it's amazing that the people here have survived. There are more people who are former deceased members of our group than there are current members. So everywhere we go with ghosts. Every place we sit, we have former board members, former treasurers, former presidents like Charisse Keewatin, former sergeant at arms. All of these kinds of people are with us, and we sort of stood on their shoulders. As the overdose crisis was starting, before it was officially declared in Vancouver, we felt it. We felt it in 2011, 2012, 2013. We knew something was wrong. And so when the province went to change the formulation of methadone, we started raising our hands saying, let's be really careful with big policy moves. Moving to methadose may not help. We weren't listened to. They did. It proved to be less effective. Lots of our members died because they were on something that was supposed to replace heroin, replace the opioids. It didn't last as long anymore. We kept trying to reform the methadone system, not by asking for the moon, not by asking for major changes in law or major apportions of funding or something like that. Just change the small things that act as barriers. Small things like it's very difficult for us to get take-home doses. Most of us have to go to a pharmacy every single day. And when you go into the pharmacy, they pour your dose, and then a pharmacist watches you take it because we are not trusted. And so we get a message every morning, not trusted, not trusted. When we go into a private, they're mostly private for-profit methadone clinic, we often have to piss in a cup. We often have to get a urine screen to prove, one, that we're actually taking our methadone, and so they can watch if we're taking other drugs as well. Not trusted again. So we're stuck in this sort of privatized system, which is a combination of healthcare, but also criminalization. So we feel the effects of that sort of watchful eye over us at all times. And not everywhere in the world does this. A lot of other places have more liberal policies towards methadone prescribing and all of these other medications that I just mentioned, such that you get a way higher percentage of daily drug users on this stuff. So here in British Columbia, people who are on all of those medications might total 20 or 25,000 people. And the government of British Columbia admits that there's 100,000 of us who are like daily opioid users. So that's a quarter at best. And that's very poor by other sort of developed and European nation standards. So we come before you to say our little group, part of Vandu, is begging for reforms to the methadone system such that we don't have to suffer these humiliations, but also these reforms keep lots of us away. They keep lots of us from even getting there. And as we try to build out more and more prescribing of better medications, we can't continue to bring these rigid old ideas forward from decades past. We have to open the doors to all of this stuff. Because when you can't get access to it, you're 100% reliant on the contaminated street drugs and you're 100% more likely to die. So we're suggesting that the province has the power to reform their prescribing system. Not only the power on regular times, but since now it's an emergency, a declared public health emergency, we've seen the power of the Bonnie Henrys of the world, of the provincial health officer to order things to happen. And we
court cases.
That's right. Yeah, we have done, and so we want to see the province use the maximum extent of its tools possible. Our comrades have come here from Vandu and other organizations to tell you how important a heroin co-op model is, how important safe supply is, and we are part of those solutions as well. Every day we're building them. But we also know that lots of people live in really remote places in British Columbia and need access to regular prescribing. And we've got to modernize regular prescribing so it is nimble enough to keep up with what's happening in the contaminated drug supply. We're going to go around the table and talk to a few of our members have direct experience with this. I'll just tell you, the private clinic fees I've paid since I've been on methadone total $10,000. This is a Canadian public health care system. Half the people on methadone like me work, and you don't get it funded, you don't get it subsidized from anywhere else. I have probably given a swimming pool worth of urine to be tested there and spent a lot of time in pharmacies. These things are barriers to us. We think the province could fix all of the things. We're going to go around and tell you personal experiences with them. But not only that, we'll help you fix it because we don't trust the province or any government to fix it properly on its own. So if there's a table of decision makers, a cabinet committee of the ministers responsible, we will sit down and go line by line through this and fix it. And I'll tell you, you can make a massive amount of ground without having to change any laws, without having to spend millions of dollars. Even within what's already set up, we can make a much more liberal and effective system. So, hey, Laura, do you want to start? Shall we go around?
Sounds like it.
The one thing I need to start with first is okay, every program that we could use and that could be changed has already been designed from start to finish. No longer can guidelines are not working unless these things that we have been invited to time and time again to not just oversight or give our advice right, unless they're changed into policy, they mean absolutely nothing. Because every single clinic, and not even just every single clinic, but a doctor in those clinics can each have their own decision on what policy or guideline in those that they want to use. So maybe this doctor in the same clinic that will be the doctor to use the fentanyl patch will not prescribe the next patient Metadol. There'll be a pharmacist, there'll be a clinic on one part of the street that will prescribe the opiate that you ask for, not just for pain, but for opiate replacement or safe supply, but something that you have a discussion about, not just what you're told. My biggest thing today is we have been working for many years with policy
makers, the people that are in the position to make these changes. During this time, we have lost this year already. We're gonna be topping 200 and I don't know 600-700. And the thing is we're 6 years into a health crisis. The thing is that we already know what could change this. There have been programs and policies implemented, and the research numbers, and I hate this saying numbers because we're not numbers, we're names. I'm Laura, Brian, Garth. And the thing is that until these things are implemented, it's not a maybe anymore. It's not I might die. It's I will. If I do not stop street fentanyl, I will die. Not I might, I will die. The numbers show there are still 6 people a day dying in BC. That's a large amount of people to be dying in a group of people that are really it's larger than you would expect, but it's not just maybe it's drug seeking, but it's health care. People have the right to put things into their bodies that make them have a better quality of life. Since I started at the Vancouver Area Network of Drug Users, 2008, I have not been in jail. I have done no crime. I have obtained a full-time, part-time job with the hospital. I now pay taxes. I'm about to move into a new place. And actually, Vandu wrote my last parole letter from what I used to do is I was a jewelry store robber. And that was to support my opiate replacement therapy because withdrawal petrifies me. Well, I no longer need to do that because we have these programs. But the thing is that there are so many opiate replacement therapies available, but it's almost like a popularity contest to which one you're allowed to have. So we have a clinic that is prescribing powdered fentanyl capsules, but only if you can pay for it. We have people who are going and asking for a fentanyl patch, opiate replacement prescription, and can't receive it. And still needing to have a special exemption written for it. In February 1st, 2014, when we switched from methadone to methadose, which if BCA-POM didn't do the work that we did, and myself with the BCA-POM board at that time didn't design the poster that we did, that was sent to every pharmacy and doctor in BC, nobody would have known about that change until the day they picked up their prescription. The thing is I had been clean 5 years, up until the 6th of February 2014. And I am now, to this day, still on my way back to that. And that's 550 mils of prescription fentanyl patch. And that was a decision made by the province with no conversation with us and with 5 now research papers between the states and here, between 75 and 80% of the people that were switched between those medications have either relapsed or went up in their methadone prescriptions thinking that that was going to make it better. So during that time now, do you know how many of those people are now dead? Policy needs to be implemented. Guidelines, they're guidelines. I'm one of the second people ever to be hired as a person with lived and living experience as a drug user to write programs for drug users. But unless the policies that you have hired or I have been hired to write and implement are made, then I feel like I'm just being tokenistic so that people can be told, we have a drug user that's hired that's helping us. Well, they're still seeing thousands of people die a year. Thanks.
Ryan?
Yeah, thank you, Laura. My name's Ryan Widow. I am the secretary.
Can you move the mic over in front of you, please?
I am the secretary currently of the BCA POM organization. Yeah, I don't have a lot to say. I believe my fellow members have said quite a bit already. I will say that I think it's evident that we have the data, we have the evidence, we have the studies that show, that we need to make changes in a certain direction, that, that we are, and not just with the methadone or, the OAT area. It just goes, in the whole, the drug laws that we have on the books currently need to be changed, and we have the evidence that shows that that this needs to be changed. I think it's fair to say that the majority of not just policymakers or government officials or drug users today, but the majority of the population knows that the drug war has failed. We hear this all the time. However, we still continue to operate in the same policies, under the same protocol, and it doesn't seem like we are in any major hurry to make these changes. I know you hear about it a lot more, it's talked about a lot more these days, but it doesn't seem that the required policies are changing. And you might say that, well, we have decrims coming in, there's a lot of changes happening, but we're not seeing any less overdose deaths. We're still setting records. So the changes that need to be made are not being made. However, getting back to the methadone and trying to stay on topic here, I'm 43 now. I initially sought methadone as an avenue that I wanted to take to get off drugs, or just something that I needed in my life at the time. Was roughly 20 years ago, or 23 years ago now. I think I was around 20, and I was living in Ontario when I first went to a doctor, or a methadone doctor, and things were quite a bit different back then. When I asked why I need to give a urine sample on a day. No, sorry, it wasn't. It was why I asked, why do I have to have my doses observed, and why can't I bring my medicine home with me? The doctor looked at me and said, because you're an addict and you can't be trusted. So it is, you don't hear that anymore these days. However, it's only the attitude or the reasons that we are told now that has changed. It's the methods that we still have to follow, or the protocol we still have to follow, as Garth mentioned, giving our urine samples, having our doses observed when we take them. None of these things have changed, but the reasons why we do have to do these things have changed. It's what we're told, at least. So my experience, though, recently, I was off of, wasn't taking opiates, or wasn't dependent on opiates for about 8 or 9 years, until about 1.5 years, 2 years ago. Kind of coincided with when COVID became an issue. I had a bad toothache, or tooth pain, a bad tooth, and this happened right when all the dentists closed down and they couldn't get a dentist appointment. I called the hospital. I was told, no, don't come to the hospital, because for certain, whatever reasons. So I made a decision to find some painkillers, and at this time, I had never done fentanyl before, but this was all that was available now. So long story short, I became dependent quickly again, and needed to find a new methadone doctor. So when I did, I'm trying to summarize a bit, but a lot of things opened my eyes to how things are done, and how I was able to, I don't know how I want to say this. I had a lot of anger when I came back, and I wasn't. I moved from Calgary, where I initially got back on methadone, and I had been receiving carries because I had reached my, I think it's a 6 weeks of clean urine. I don't like the word using the word clean, but negative urine samples for other drugs. So I was able to receive carries where I could have take-home doses. So then I moved to Vancouver because I doing my master's at SFU now, so I needed to move back to Vancouver. So when I got here, I expected to have my prescription just switched over and be still receiving my carries. However, that wasn't the case. I was now told that basically I have to start over. My doctor, wants to get to know me, or all these just the same, more of the same issues that are, as I will get to. I kind of just started to realize that these are just made up reasons. So to get to that point, I had a lot of anger with my doctor around this, and then I felt very degraded of having to be observed taking my medicine. Could be at maybe this is my personality or where I was now at in my life, and the education I've received, but I just really started to seeing it as discrimination, having to have another adult or another person watch me take my medicine. I don't know if you can relate to that or try to think about how that would feel, but
96% of the people of us that are on methadone, Ryan, are all.
That's what I'm trying to. Yeah. So if you could think about if you were given some medicine and you were told that you have to take this in front of another person. So they thought they had a solution for me. They just said, well, we can have it delivered for you. So they didn't really get too much into it. I wrongly assumed that this would mean they delivered it and dropped it off at my house. No, this now meant that basically not a pharmacist who delivers it. Basically, a pizza delivery man basically came to my door and asked me to take my medicine in front of him at my door, with my neighbor standing 2 feet away from me at their door. So yes, this didn't. After that day, I said no more of this. But then I started to, and this is the point that I'm trying to get to, that I started to have discussions with my doctor, and I could see that she really did want to help, but it was evident how handcuffed she was with that, or how handcuffed she thought she was, or how scared she was of having to explain herself to the College of College of Pharmacists. But as we started talking more, I started to realize that these things that I've been told over the years from multiple different methadone doctors, that you have to have 6 weeks of clean urine tests or negative urine tests. You have to there's multiple different rules that you have to. If you other drugs show up in your urine, or you'll be cut off, or your carries will be taken away. As we're told, I'm sure you can all kind of clarify or agree with this, that our doctors tell us that these are mandatory things that we have to do, that we have to have 6 weeks of clean tests, we have to have no other drugs in our urine, we can't miss a day. If we miss a day, we go, there's all these rules that I started to find after talking with my doctor, that these aren't mandatory rules set down from the from above. These are the doctor's choices. The doctors can it's discretion. They can give you your carries on the first day if they want. But the point I would like them making here is just that there needs to be clarification. There shouldn't be lies to the patients being, what we are required to do, and there should be guidelines that, and not so far as that we should have, when we should be taking urine tests and things. The guidelines should be that we are taking medicine and we should be treated like anyone else who's taking medicine. Same if I got in a car accident, or if one of you here got in a car accident and you hurt your back and needed to be on morphine or a heavy, a powerful painkiller. You wouldn't expect to have to take this medicine in front of another person. You'd expect to take it home with you and be treated as an adult that can be trusted. And I won't be done, fighting until that's how methadone or Acadian or Suboxone is treated, in that it's medicine like any other medicine, and we're patients like any other patients, and our wants and desires and needs for what medicine we want and what we think we're expected for us should be implemented. And as I said, we need to be treated like any other patient taking medicine, and that's what I think.
My name's Jeff Loudon. I've been on the fentanyl patch for a couple of years because I couldn't do that methadone crap. Cough syrup, as far as I was concerned, it didn't do anything for me. But the fentanyl patches, I'm on a little bit more than Laura. But it's taken probably 2/3 of my pain away. I'm on it for chronic pain. Man, I guess I'm an addict, because these idiots won't do any of my surgeries. But there's a lot of people that would benefit if it was easier to get on these patches. Like, it seems to be a clusterfuck to get on them.
There's still a
They'd run you around for a month with sob stories, and then you have to wait forever to get up to the dose that you require. Like, they raise you up, what is it, 50 micrograms or whatever it is a week.
If you're lucky.
Yeah. Well, I'm on 1,000, so you figure out how long it took me to get there.
Yeah. And that's it.
And it still ain't enough.
Yeah. That's it because they wrote to the government to ask if you could be on the fentanyl in the first place. It's accepted.
And there's no evidence or studies behind that showing why they do it at 15, or they just pull it out of thin air.
Well,
this is what we think, or seems like it at least. Sorry.
No, it's go by good old Christy Sutherland there. She's running the program. That's self-explanatory, I think. But I don't know. I think you should change the guidelines on that, like especially at the amount of people started at. I don't know what you started at, but I started at 400. And it still took forever to get where I'm at.
I started at a higher level than normal because I ended up in the hospital actually with serotonin syndrome because I had a reaction to the diacetyl morphine. If I would have started using it.
You want to go, Brian?
Yeah.
Hi, Brian O'Donnell, current Sergeant of Arms of BCA POM, and I work with also on the board at Van Du as well. I am Sergeant of Arms of Van Du as well. Yeah, so I'm myself am on 210 mils of Metadol D. I wasn't stabilized till about 180. I wasn't on the original methadone, but a lot of my friends were, and they all relapsed, and I'd say about 80% of them are now dead. And it was like they were forced to use, right? So I'm sick of this, and I'm mostly sick of the stigma that, we are human beings, not human doings. Why are we judged for what we do? You know what I mean? It's ridiculous. If people want to divert their drugs, obviously then they're not getting the right things, right? They're not getting what they want, right? So the doctors are in control of that, right? They feel, and they always say their hands are tied. It's up to you, right? So you guys make the policies. So, but the doctors, I know, have the rights to be able to pick and choose who they want, because I know a lot of people who they go right in and bam, they get what they need from the doctors, right? So we want to end this stigma all the way up to the top, you folks, right? And nothing about us without us is very important. Okay, if you're going to make policy about drug users should be part of it, right? Definitely. Happy that we're finally in the room, right? But it's really, 7 years too late, really. You know what I mean? Like for the amount of people that I've lost. I'm just disgusted with the way the system has gone. We still have this methadose on the thing, and it definitely does not have any legs at all. It does not last long. It forces people to go out and use. The doctor's telling them it's the same thing. They're still telling them that it's the same, and it's not. He should be telling them once it doesn't work for them, they should be encouraged to be a different medication, but they don't. They come to our meetings and we tell them, and it's all news to them. What's Metadol D? They've never heard of that. And why aren't the doctors? And sometimes the doctors are even saying that doesn't exist, right? That's just a pipe dream or whatever. No. Why would the doctors lie about that? You know what I mean? It's maybe the doctors are not being informed to keep it a secret, right? To keep us, because we're just subhuman, right? That's we're not real part of the program, right? But we are. We're all a part of society, every single one of us, right? So I'm just sick of the way things are going, and we have to change. Things have to change. So that's real all I have to say. So, Howard, thanks.
Hello, everybody. I got some interesting things to tell you, folks. I'm going to talk a little bit about money. First of all, I'm going to tell you a little bit about my story. I came from Alberta, 2014, 2015, and I am a chronic pain victim. I've got spinal stenosis from C4 to C8. I've got a popped disc where my vertebrae is pushing on bone, pushing into my spinal cord. Herniated disc from the top to the bottom. I have a lot of pain. I'd been on hydromorph for years, and that was working very, very well for me. I was on just over 100 mgs a day. When I came here, I could not find a doctor that would touch me. They said, no, we can't give you that. That will kill you. And I said, well, I didn't start on that dose. That's where I'm at now, after years. But they wouldn't touch me. Instead, they forced me to take methadose. And I begged the doctor not to put me on it because I had already done some research and found out that it was poison. And actually, the bottles actually say poison on them. For a year, I was on that drug and sick every single day. And they did not care. They forced me to walk to a pharmacist every day for 3 months to go and get my so-called pain medicine. And there was no reason for that. They called it policy. Why would you force somebody with chronic pain to have to walk to go get their meds? That was absolutely bizarre in my mind. I joined BCA POM because of the fact that they were actually doing something about this. And I did some research and I found out that in this area here, there's close to $250,000 a day that are taken out of the community to pharmacists because of daily dispense and witnessing. Once you walk through that pharmacy door, that's $10 right there, then they get another $15 to witness you take your meds. There's only 4% of the people in this area that actually have carries. The rest have daily dispense. And they say that it's to stop diversion. Well, that's absolute nonsense.
It doesn't work.
It does not work. And instead, we're getting, toxic drugs from all over the place. And I could not tell you how many of my friends have died from this nonsense.
Far too many.
There's no reason why, as a province, we cannot actually grow our own poppies, make our own opium, process it, and give it. We could supply all of Canada very, very easily. You guys go out to Abbotsford, you take a look at all the greenhouses out there, all the fields. We can do this. We have enough smart people that we can do this. Instead of relying on toxic drug supplies, we can give safe supply.
Yes.
And that's just with the opium. Can't say anything about cocaine or the other drugs, but with opium we can do that. And there's no reason why we can't. There were some other things I wanted to say. There's what they've been doing, like the College of Pharmacists and Physicians, they're guilty of crimes against humanity. When they switched from methadone to methadose, I worked in 3 different overdose rooms. I actually walked and talked with Thomas Kerr to get these rooms opened when we were doing the alley patrol. And he told me straight out, in the 90s it was bad. It's a lot worse now. And it's terrible. We got the rooms opened. I've worked in 3 different rooms. I've had guys come from all over the place, from Surrey and different places, and tell me that they had been on methadone for up to 20 years and never ever chipped. When we did the stats, 80 to 85% of the people, when they were switched from methadone to methadose, 3 days they started chipping. They were looking for heroin on the streets. And that's when fentanyl was brought in. I call it systemic genocide. They're getting rid of a certain class of people that they don't want. And I believe that to be true because of the evidence that I've seen. And I know that's very strong words, but I believe that to be true because of what I've seen. When you look at 165 people every month that are dying from a toxic drug supply. It's insane, you know, family, friends, you know, somebody's kid, somebody's father, somebody's mother, you know, it's not right. And when we have the ability to stop this from happening, you know, let's do it. Thank you.
Do you want to say what chipping is?
Huh?
Do you want to say what
Oh,
chipping is?
chipping. Chipping is going to buy heroin off the street. That, you know, that's what chipping is.
Howard's comments make me also think of one thing. It just goes to show like the reasons that they give us are just silly and made up. Where Howard mentioned that they want us to do reserve doses because they don't want us to sell our drugs on the street to other people. That's one of the reasons that we're given. Another reason we're given is that they don't want us to overdose while we take it, which makes no sense because methadone or the others doesn't kick in for about 45 minutes to an hour after you take it. So if you take it in as an observed dose, you're already out of the pharmacy before it kicks in. So it just shows that the reasons they're giving aren't any logical reasons. They're just making up something to have a reason.
Thanks, everybody. If you guys got questions, we can do questions.
We'll go to you, Caitlin, and then we'll have our question and answer. Go ahead.
Sure, yeah. I can assure you my presentation is going to be far more boring than what you just heard, but I can hopefully get into some of the legal mechanisms that are at play here and some of the concrete actions that the province can actually take. So I want to situate my discussion today in the reminder that the power to legislate matters of public health within the province belongs to the province, and that authority is constitutionally sanctioned. So that means that when municipalities and the police and the professional regulatory bodies like the colleges of physicians and pharmacists, which we heard a lot about earlier, when these entities take measures that actively interfere with public health, the province does have recourse. The province has powers under the Constitution, under the Community Charter, under the Public Health Act, under the Health Professions Act, under the Police Act. There are many powers that the province has access to, but these powers remain unused at direct cost to the lives of people who use drugs. So most of you, I'm sure, are familiar that in 2016, BC's Minister of Health issued an order requiring that overdose prevention services exist around the province. This order is nowhere near being fulfilled by the province or the health authorities. Instead, it is drug users and their allies that risk their lives and their liberties to establish sites and services to save lives. And they do so under constant threat from local entities whose actions go virtually unchecked by the province. So today, Pivot is asking the province to grasp its legal and ethical responsibility to support what is really your greatest asset, which is drug user-led groups like BC APOM and Bandu. I want to make recommendations that kind of go to 3 sites of power abuse. So that's at the municipal level, at the police level, and at the level of the colleges. Firstly, I want to talk about a recommendation that the province stop municipalities from undermining harm reduction efforts of people who use drugs and drug user-led groups. Reminder that municipalities are creatures of provincial statute. They do not have inherent or constitutional legislative powers. Their ability to create laws and policies and practices derives from the province. And so it's the province's power and responsibility to step in when municipalities are undermining these critical health services, which they're doing every day. In the last year, I've worked with 4 separate drug user groups whose harm reduction sites have faced closure because of municipal zoning decisions and business license denials. These sites are almost always operating in municipalities where there's no other harm reduction services. People are getting their sterile harm reduction services from a truck at the McDonald's parking lot, and yet when drug users are trying to organize to set up a concrete location where people can readily access consistent harm reduction supplies, they're getting shut down. We first called on the province to act on precisely this issue in 2014 to no avail. cities are amending their zoning bylaws. This is kind of the mechanism that they're using. So they're amending their zoning bylaws to create new land uses like harm reduction services, supervised consumption sites. And the effect is that existing harm reduction sites overnight are not in compliance with the bylaws and they have to shut down. I've seen this happen over and over again over the years. Amendments like these also prevent hopeful harm reduction sites from setting up because suddenly they're in a community where they have to have one of these zoning uses. Nowhere in town is zoned that way. The only way to do it is to apply for a rezoning process that can cost thousands of dollars. Drug user groups can't afford that. They are busy saving lives. No one is out there helping them, and they're just trying to set up harm reduction services when everyone in town is trying to get them shut down. Clearly, these zoning decisions are impacting public health, and under the community charter, municipalities have to obtain the approval of the health minister to pass any law that impacts public health. Municipalities aren't taking that step. The province isn't monitoring it, and it's not intervening either. BC Court of Appeal has called out the absurdity of this exact practice. In 2019, it said that this provision of the community charter, the provision that requires provincial approval of public health related decisions or decisions that otherwise infringe on provincial jurisdiction, they said, quote, "It's very badly drafted." And this has led to municipalities sliding in health policy under the guise of zoning decisions, zoning legislation, all without provincial oversight. So we're asking the province to immediately begin monitoring and intervening when these types of bylaw decisions are happening. We're also asking the province to amend the community charter to make it crystal clear that that provincial approval is in fact required anytime a health decision is being made by a municipality, including zoning bylaws and business license denials. And we're asking the province to engage in good faith with the 2016 ministerial order that requires overdose prevention sites to be established where there is need. At this time, there is no community in BC that isn't in need of overdose prevention services, and yet there are tons of communities that have no place where people can go and receive overdose response on a consistent basis. I've been told firsthand by various health authorities that sites are typically only being established upon request from municipalities. This is unsatisfactory, and it goes directly against the order, which says sites based on need, not politics. So whether or not a municipality agrees in principle with harm reduction should have no bearing on whether drug users have access to health and harm reduction services. Additionally, in addition to fulfilling this 2016 order, we also ask the province to invest in property for the use of drug user-led groups and realistic funding for their establishment and continuation. I'm conscious of time. Do I have?
You have about 8 minutes and 30 seconds.
Oh, okay.
You'll see a yellow and a red light on that thing.
Okay, cool.
I know, I promise you we don't do that.
Green light's good.
So our second recommendation is that the province take a more active role where police are interfering with harm reduction in drug user spaces. We didn't even have a chance to get into that today, but I feel like we could have a whole other 3 hours to talk about police interference. A recent study by the BCCSU said that police frequently loiter outside of overdose prevention sites and drug user spaces. The study concluded that people will oftentimes not access an overdose prevention site because they fear police interaction or arrest.
Like right now, today.
I was just going to say, I spoke to an overdose prevention site operator, service provider in Vancouver yesterday. They said police had been standing out front all day. They were asking people for ID before they go in. And the service provider said they witnessed numerous people turning around and leaving. People will not access these sites if they know police are out front. We're at a, exactly.
Police are fear. They're stealing from us all the time. The Crown's been saying they don't want to have any small crimes. So the police have been self-enterprising by stealing the drugs. And where are they? Where are these drugs that they've been taking, right? They've been taking drugs and money from us. Where does it go? I want to be able to see it in a lockup somewhere. I want to be able to see it. Sorry, Kate.
No, that's fine. And actually, Brian, this is a recommendation that you came up with in one of our last meetings. So given that, we have the province encouraging everyone to make use of supervised consumption sites, overdose prevention sites, at the same time, people have no legal means to leave from their house to a site with drug in hand. There's no legal protection. So one of the things we had talked about in our last meeting was that we want the provincial government to legislate bubble zones or safety zones around drug user spaces. Under this policy, the police and other detractors would be prevented by law from entering and loitering in these zones, except, of course, in cases of emergency or exigent circumstances. Province did something similar in the context of abortion clinics. 1996, Access to Abortion Services Act said that because the presence of protesters was detracting people from accessing these health services, legislation needed to be passed. We're in the same circumstances now. If we know that police presence outside of sites is preventing people from accessing a life-saving health service, then we should be legislating accordingly.
They are dying. They will not come in.
Absolutely.
We've had 0 deaths at Bandu in our IR, right, in our injection room. So.
But not in our alleys.
But in the alleys and the streets, when people are deterred because of police going into the places, they die, right? They end up going. And if they can't access, or if police are going to concentrate on going after the big dealers, maybe they're going to shut down the good drug dealers, the ones that have the clean drugs, right? So then they're going to be turned to the poisonous drugs, right? That's what's going on, and people are dying. People go out and they smoke a bit of crack, which shouldn't kill them, and they're dying of fentanyl overdose. What's going on? Is it cross-contamination, or are there people out there murdering us? That's what it seems like. It seems like there's murderers out there going out there.
Genocide.
Yes. That's what it feels like to me, anyways.
Another action that police are regularly taking, and this is quite shocking, is that they're detaining and investigating people for carrying basic harm reduction supplies like crack pipes and syringes. So I speak with defense lawyers around BC every week who spend their days defending people who use drugs in the criminal justice system whose arrest stemmed from merely possessing basic harm reduction supplies. This practice has a clear chilling effect on people being able to carry the supplies they need, even as the province and the health authorities are encouraging them to carry these health supplies as a best practice.
Not only that, they're taking our marked pills that are our safe supply prescriptions that have our names on them. Yeah. But because some of us do not carry ID, they do not know that they actually belong to us, so they're obtained.
I had a pig tried to pull my patches off because he said there was too many of them. That couldn't be from the doctor.
Holy shit.
If you're walking and talking.
Yeah. Thank you.
Yeah.
I didn't say that.
Thank you.
I had a friend of mine, he's an outreach worker. He got shaken down by 2 cops. He was in the alley right behind the Carnegie.
Doing outreach.
And yeah, he's got his bag over his shoulder. He was talking to 2 people. Next thing he knew, he was up against the wall with an arm across his throat and his cop whispering in his ear, "Give us your money and your dope and things will go easy."
See?
Yeah.
And so they let him down. He took out his wallet. He had $5 on him. He says, "This is all the money I have as far as dope. All I have is harm reduction supplies." He made them look like fools, but the fact was they tried to shake down an outreach worker.
In small
And
rural
that's
places,
evil.
there's still bylaws if you have harm reduction supplies on you. I used to get $100 fines in Kelowna when they would find a piece of Brillo on my possession. The thing is that now, decrim is great. With decrim, legalization would make it work even better. But it feels to me almost it's a win, but almost a backwind, because it almost feels like now it's opened the door for them to stop any person that they think might have drugs on them, to be able to check if they are carrying the amount that they are allotted. So now it is almost like they have probable cause for every person that walks the street on the downtown east side.
Decrim and just the broad term of it sounds like it's a step in the right direction, but however, how we set up decrim can make it worse or better than we are doing right now? And it seems like the way it's going right now could be worse.
We should let Caitlin.
Oh, this is really good context, and it's completely in line with the recommendation that we're making, which is that, so Laura mentioned these bylaws that prevent carrying harm reduction supplies. That's a clear example of a bylaw that should not have received enactment without provincial approval. That's a bylaw passage that the province could be monitoring and intervening in to say, these are health supplies that you're carrying. You cannot pass a bylaw that says you can't carry health supplies. Exactly. Oftentimes these are supplies that are handed out by the health authority and then confiscated by police and the person's arrested. So under the public...
Just because I'm wearing a St. Paul's tag. If that's not showing, they've taken it away.
So there's very...
and I've gotten them back.
We can see how application does not look the same for everyone. Different people are targeted by the laws, and the fact that this law has as its heart a prohibition on carrying health supplies should never have been passed in the first place. There are powers that the province has in terms of reallocating or redirecting police resources away from things like simple possession and street-based drug trafficking. Street-based drug traffickers, oftentimes drug users themselves, are providing some of the only safe supplies right now that people have access to, given the total lack of state-sanctioned alternatives. BC also has one of the highest sentencing ranges in Canada for people who traffic in substances that contain fentanyl. It's incarceration of 1 to 3 years. I believe it's only BC and Ontario that have that sentencing range, and it's the highest in the country. An amendment to BC's Police Act that that diverts funding and police resources away from the enforcement of simple possession and street-based drug trafficking is possible. Something like this was recommended by Dr. Bonnie Henry in 2019. Even though the province has taken steps to decriminalize, the result we've gotten is 2.5 grams. That's not going to protect anyone in this room.
The police wanted 1 gram. It's like
the police wanted 1 gram.
There should be no threshold at all.
If the province is committed to
metabolism.
full decriminalization, it can take this recommendation from Dr. Henry. I've reminded the province of this several times. I've been told that there's no legal avenue by which to do it. That's absolutely not the case. The report itself contains a legal opinion that I myself wrote. I can say with certainty it is absolutely legal and possible to do. It just requires political will. There can also be a directive from the Minister of Health under the Public Health Act that goes to police and the BC Provincial Court to say harm reduction supplies are health supplies. It's not drug paraphernalia, and it shouldn't be treated as a crime to carry them. Am I almost out of time?
Go ahead.
Okay, I'll just say one more thing. So, and this kind of dovetails with all of BCA POM's recommendations, but from a legal perspective. So you've heard about many of the restrictions to safe supply, whether it is bans on carries, mandatory witness doses, urine tests, narrow prescription guidelines, doctors being unwilling to prescribe. Time and again, I've heard people in this government claim that the chief barriers to safe supply lie at the level of the colleges. This is not the case. Sorry, it's not that it's not the case that it is the colleges, but it's not the case that the province's powerlessness in front of the colleges. So in May 2020, this province amended a regulation under the Health Professions Act. It's called the Health Professions General Regulation. Section 13 of this regulation says that the provincial health officer can make an order that effectively overrides the regulated health professions, the colleges, in the event of a public health emergency. So these restrictions that limit people's access to medical safe supply, to the extent that the colleges are involved, that can and should be overridden.
There were things, they changed it. It was, till 2022 at one point. Now they've changed some of them till 2026, which are different, some of the regulations to the College of Pharmacists, which happened within like a 3-day period. So like it's like, giving, pharmacists now have the ability to, quote, write emergency safe supply prescription for 2 days if somebody misses a doctor's appointment, and so that they don't go to an illicit street drug. Something this can happen within a pharmacist is given permission within. They changed this within like a 3-day period of time from something that had been was to be stopped within September 26, 2022 is now till September something 2026, which gives now pharmacists the opportunity to prescribe safe supply in an emergency where somebody misses a doctor's appointment. Like, this is what is saving lives. It's changed, and it's you can do it. I'm leaving this meeting because I have somebody who needs me to help them to get onto a prescription that they've been denied. But the thing is I left because I feel so defeated right now because my friends are dying and I'm dying, and you people are the people that are the ones that can make this stop, and that responsibility is your responsibility, and I have to say that it's also your responsibility that it's happened, because it's 6 years, and it's been 6 years, and you can't tell me that in 6 years that not one person in this room sitting at this table hasn't lost somebody in your family to an opiate overdose. That didn't need to happen, because there are medications that are made to fix this. In 1989, the Australian Drug User Union, you need to read some of their information.
Thank you, Laura.
Thanks,
Laura. Love you.
I'm sorry, no disrespect, but I can't.
She's an advocate. She's
This is a Laura Schaefer mic drop.
That's what we call it. Yeah, but she's very busy. Yeah.
So, is it okay if we switch to a little bit of questions and answers now?
Please,
I think we should probably have about half an hour for that, if that's okay with everybody. We're a bit over, but
I
that
actually have
should
to
be.
leave about 15, but
Okay, if you have to leave, you have to leave.
Yeah, I know. but
Okay.
this is more important.
Yeah, I just want to say at the beginning, on behalf of the committee, thank you for coming, and thank you for speaking so openly with us. It's really invaluable to hear all of your experiences and what you see needs to change. It's really a good lesson for all of us to hear that. And I also want to just acknowledge the pain that was talked about whether it's physical pain or the pain of loss that you've all experienced, and that we certainly have all definitely been touched by some of that in some way, as Laura said. So we'll go to questions. Go ahead, Dan.
On the end of the list, but thank you very much, all of you, and good to see a couple faces from the Reforming the Police Act as well when you guys presented. So I'm not sure the best way to ask for this, and between that committee and what we've heard about here is that continuum, right? I mean, right now we're dealing with how do we stop the 6 deaths a day? Yes. That is critical. We look at, the long-term piece around the recovery and getting those supports. The prevention piece, which is, they're all important in this whole spectrum. So loud and clear on what we're dealing with right now on the people dying. Your message, very clear. Just in light of time, and I know that we're short of time, I wish we had much more time, but can one or two of you talk to us about what could have made a difference for before you started using? If government needs to act on the prevention piece right now, what could have made a difference? I hope that's a clear enough question. And
for one thing, go ahead.
Garth, please.
Well,
yeah.
Garth, I think the government you guys are legislators, the government legislating to the full extent possible. You know, the government instructing its deputy ministers to roll out the regulations to the full extent possible, like Caitlin was saying. So that when someone's getting wired, you could actually get on methadone. Or we had a prescription heroin program here. It was frozen at that little sample study group. I just sometimes imagine, what if the province had boldly said, we're going to have prescription heroin here? In 2003 or 2005 or 2010, we wouldn't be sitting in this room. We wouldn't have the fentanyl crisis. So to me, prevention is prevention of death, right? The question of preventing people from trying drugs to begin with, I don't know about that. Everybody tries drugs. It just happens. We could also make mental health care the same as regular health care, funded. The current government talks a lot about health care, but we don't have funded health care, right? So most people don't get access to it if that's a source. So I think we're here to tell you about prevention of death. And prevention of death is giving people as many pharmaceutical alternatives to the poison street supply, certainly a co-op model, but also within the province's mandate of prescribing within its area, and that keep up with the contaminated drug supply too. So methadone has been pretty good for a lot of us, especially if we had habits in the time of heroin. But as the drug supply has gotten stronger and stronger, it's kind of feels like light beer now, and you might need something a little stronger than that to get across. But that's prevention of death. Sorry, Howard.
No worries. One of the big problems too is we do not have proper detoxes or treatment centers in this province, unfortunately. I think that goes all the way across Canada. But I worked for the BCCSU as a peer navigator. I was helping people get off of street dope onto prescription drugs. But when we tried to get people into detox, there was so many barriers. One fella, he's in a wheelchair, one of my clients, he's in a wheelchair. It took me a month to finally get him into a place where they could accommodate his needs. He was there all day, just happy as a clam that he could finally get there to get off the dope. At the end of the evening, he asked them if he could go outside and have a cigarette, and they said no. It's a non-smoking facility.
That's not what he's
and
going to quit.
he said, well, you better call Howard, because I can't do this. I'm trying to get off of dope. I'm not trying to quit cigarettes. Yeah. And so they called me and they said, we have a problem. And I said, I talked to you guys for a month. I begged you guys to bring this gentleman in. And not one of you said that it was a non-smoking facility.
Not once.
If I would have known that, I would have looked somewhere else. To make a person quit absolutely everything at one time, that's bizarre. Yeah. But that's what they did. Yeah. And even in Insight, or Onsite, I guess it's called, it's a disgrace. They told me that you have to go there every day for a minimum of 2 weeks to prove you really want to detox. I'm not kidding. This is what they told me face to face. You have to go there a minimum of 2 weeks to prove you want to detox, and then maybe they'll let you in.
They'll lie and say they're full every time.
So
right?
In 2 weeks, you can be dead. You got no choice but to take the street dope or whatever you can get, and when you're trying to get off of it, they're making people suffer needlessly. And it's a disgrace. That really truly is. We need more and better detoxes. Places too that let cannabis be used as well. Cannabis is proven. I started the CSP in Victoria. When I was over there, I worked in 2 different detox or overdose rooms. I worked for Solid. And I don't know if you might know them. Yes, I believe we actually met before. Yeah, and Dan, I believe we met before too. And we started the CSP over there. It's going great. They've got thousands of members. People really appreciate it. Here, unfortunately, there was 4 of us went to City Hall and we talked to Rebecca, can't remember her last name, but we got support from the city. Neil, who runs the CSP here, the Cannabis Substitution Project, he's been busted 4 times.
Please keep taking his things.
They keep taking. Last time was a couple of weeks ago. They took his van, they took all his product, his money, everything else. And I talked to the cops myself, and I says, "Why are you doing this? You know, they're saving lives. You know, like, why are you doing this?" Sorry, comes from higher up.
I think Jeff's chomping at the bit to get in.
Yep.
Yeah, let
Get
Jeff,
after
let Jeff.
Sorry.
Doesn't matter. Some of us were functioning junkies. I don't know. I used to be a bricklock and stonemason until I went to St. Paul's Hospital and got some bone-eating disease. And now I'm got to be operated by the goddamn government, which is not something I want. But let's see how it goes, I guess.
I have, sorry, were you?
Go ahead.
I had, some more like focused on your question, that what could have been done differently if, before I started. And the way, if legislation and our laws and the way we did things around drugs was in place before I had started using drugs, I would have been in a much better place. And when my ideas around what that would be, I initially started using drugs both for medication, self-medicating, and for recreational use. I started, in my mid-teens, and I won't get into the details of my life, but I had gone through a lot, and I started using drugs, one, to fit in and to, be somebody that was maybe looked up to, looked as cool, and in my group of friends, but also to escape reality in that I didn't like my life at that point. However, I think if all these drugs that are available had been dealt with, or are not dealt with, but seen as same as alcohol or or other medications, where I didn't have to go onto the streets and deal with gang members and the black market, and I could have gone to a doctor who would work with me to prescribe me drugs, either whether it be opiates or heroin or whatever, because for me that's what worked for me the best for depression and getting to the point where I was able to get better. If I write a book in the future, I want to title it "Heroin Saved My Life," because that's how I see it. For about 5 to 10 years, I was suicidal. I didn't want to be alive. I didn't, if I wasn't high, if I wasn't using something to escape the reality that I was living in, I didn't want to be alive. And heroin got me to that point where I could smile during the day, I could enjoy myself, I could have a life. And it got me to the point where I was now ready to deal with my problems in a more, beneficial way, I'd say, or, a more productive way. However, there are some people, we're all different, right? Some people will use any depressant or a drug or something for the rest of their lives. And if they need to do that, then I think they should have the support to deal with those drugs, get the cleanest drugs possible, the safest drugs, and do it in an educated and, productive way, right? So that's where I think, if things were different before I started using drugs, that's where it would have to be, is that we can use drugs, use these drugs they serve a purpose. Basically every drug we have out there serves a purpose in some way or another, and we're not utilizing them in the most productive ways, I think. So, Thanks, Brian.
Thank you, everybody.
I have a few more questions here. Let's try to get to as many as we can. Trevor and then Sonia. Go ahead.
Yeah. Throughout the presentations the last couple of days, there's one thing that's kept coming up, and it's the benefit of trauma therapy. But there's for a long time now, there's been an access problem, a cost affordability problem. But in terms of what you guys are seeing every day, are you able to speak on the benefits of trauma therapy, what you're seeing, what would work better, if it's more accessible, if it's cost,
I think, there needs to be in a way that we can utilize everything that's out there, whether it's, behavioral therapy, counseling, and while also using the drugs that are out there, and speaking with, the individual and what works best for them. But I do fully believe that, those of us who are, to the point where, we're on the streets or working in the sex trade or, committing crimes to obtain the drugs we need. Yeah, I think that, we need to access all the available options out there. And I think, we do need a lot of improvements in what's out there as well. So.
I tell you what, I've had PTSD treatment. It was really helpful for me, but we're here to tell you how to stop people from dying. We're looking for solutions for this afternoon. For the next 2 hours, this is triage, right? So if you think about a roadside accident and there's people lying on the side of the road, you don't want some city engineer to come and say, how would we put a traffic light in here to prevent this? I mean, prevention is important, right? Or how would we put another airbag in the car? Those are great questions. And we can have committee meetings on that, but in the context of an emergency, it's the death. That's the problem for us, not if people are using drugs. That's not, people are going to use drugs. That shit just happens. So trauma therapy is great for us who have been traumatized, but there's lots of people who just do a bit of coke on the weekend. They shouldn't die, right? So it's it's calibrating what the problem is. And this committee, the terms of reference really focus on that toxic drug supply, right? So in my mind, sure, I agree. Let's give everybody access to really good PTSD treatment. Fucking A. But the main thing we have to do is end the toxic drug supply, and we come here asking the province to put its hands on every lever that's possible, because so many of them have gone unpulled. And we see the Minister of Mental Health and Addictions get on TV, and she says, our hearts are heavy. We're doing everything we can. Never before have so many people done so much. And I can't even hear it anymore, and none of us can at the Vancouver Area Network of Drug Users. We've just had crocodile tears for years. And that's why we're looking for those immediate triage moments. And this is one of our co-founders of BCAPOM, Ann Livingston, says, you got drug user groups, and then you got drug user groups of the lawyer. And so this is our lawyer. This is Caitlin, and she rides shotgun on all of our shit. And that's why when we had a strategy meeting about this, we're like, let's really identify for the province in as much detail as we have time for the things that we can do that would save lives this afternoon. Because this panel of people you've seen here, if we have this again next year, there's a 50-50 chance that not all of the people will be here. We go to meetings and we prepare for this meeting. We look in your book, this handout that we gave you. If you look at the end here, here's Greg. Here's our past president, Charisse Q. Watton. They've come to rooms like this and talked to people who are in this room, and they're dead. They're gone. And so it's just I think to myself, next year, is Laura going to be here with us? Is Jeff, my best friend for 30 years, going to be here with us? Is it going to be me? We don't know, right? So for us, prevention and trauma treatment, these are good things, but they're just not urgent enough,
Is it possible for me to add something? So I'm Hannah Dempsey. I've worked with BCAPOM as their project coordinator since October, and I think in terms of trauma-informed therapy, as Garth says, that it could be helpful, but. So the way in which this committee was set about takes very little responsibility for the fact that government policy is responsible for this toxic drug supply. So the war on drugs and prohibition have resulted in this crisis. So we need governments to take that kind of responsibility up. And these policies, these systems are causing trauma as we speak. All of these deaths, forcing people to piss in a cup every week. If I went to a BCAPOM member meeting and am looking in the face of someone who missed an appointment for a week because he was ill and he is unhoused, and now he has to go to the pharmacy 5 times a day. Anyone in this room who can go to the pharmacy 5 times a day and maintain any semblance of a life and not experience that as in itself traumatizing, telling that person that now they have to go to a trauma care therapy and that's going to save them, this is why we are here with these directed recommendations, that we need these punitive measures that are a part of the war on drugs. These barriers in the OAT systems are full of stigma, and they are a part of the war on drugs, which the government is responsible for. You are an actor in this war.
It is an open-air jail.
No, I don't mean mandating. I just...
Hold on a second. what I was saying is that we've had people come in here the last couple of days that have said trauma therapy is keeping them alive. Right? And that's what I was just trying to, I just want to make sure
totally.
I put that.
No, I'm not at all speaking against the like life-saving capacity of trauma therapy and therapy in general, and the real dire need for actual services and real healthcare and real counseling and care for people who use drugs and people in general. But I just think if we get caught up in that, again, like Garth said, we are in an emergency right now. We are 6 years into an emergency right now. Vandu has been feeling the effects of the they've been feeling this as an emergency for longer than when it was publicly declared by a health minister.
It doesn't feel like we're in an emergency in that from the way the reactions are. You know, we're living in an emergency. It feels like that on the ground level on the streets. It feels like an emergency, but it doesn't feel like there's an emergency going on when it comes to, you know, all the other actors or the sources that are involved. I would also like to add that, if in a hypothetical situation, if somebody is receiving, you know, trauma care and it's really helping them out, you know, the good chance that they're also still using drugs, you know, and so they could also, you know, be receiving this really, you know, beneficial care and still die, you know, and still overdose on drugs. So that's where, for me, I believe, you know, and my way of thinking is that everyone is responsible for making drug policies throughout the last 100 years is in some way holds the responsibility for creating the fentanyl overdose crisis, and is in some way responsible for everyone who has died, and that it's completely unnecessary. There's no reason for heroin to be illegal and alcohol to be legal, or illegal, you know what I mean. But, you know, we're functioning on ideology and an uneducated population, and their needs and wants seem to be much more important than the people who are actually, you know, dying and living this war. So.
I'm going to step in here. We have about 5 minutes left before we said, I just wanted to see if I can get to the next two questions so people get a chance to engage a little more before. So go ahead, Sonia.
Yeah, okay, thank you. And I think it's really valuable for us to feel the sense of emergency and urgency with you. I think this is essential. When you say pull the levers, we've heard pretty consistently from everybody who's talked to this committee about the need for regulated safe supply. And I know about Vandu's application to provide safe supply and the letter back from the federal government, but describe for us how that lever can be pulled quickly and what Vandu's efforts have been to try to pull that lever on regulated safe supply.
Are you referring,
like the co-op model, or the compassion?
In which folks are purchasing from the web and then testing and selling?
Yeah, we heard about it yesterday.
Okay.
But if you could give some more description about what that could look like on the ground, right? Like Garth, you said we need to triage. Tell us what the triage looks like on the ground.
I mean, you're talking about the Drug User Liberation Fund, I think, which is ourselves and other groups, DULF, and gives away to our membership tested heroin, coke, and meth that's sourced on the dark web, but then run through a mass spectrometer to make sure what it is. It's an act of civil disobedience, right? It's symbolic. It does not scale. We can't get the amount of material, the amount of drugs to do it. So I think what we're all asking is for the people who allow or don't allow the importation or the prescription or the distribution or even the manufacture of those drugs in British Columbia to make way for it. You know, we used to manufacture prescription opioids here in British Columbia. I mean, I know on the North Shore, my girlfriend used to work in the factory. We can again, but it's that source. That's definitely a limiting factor. And we need to get it out to people through every means necessary, every means possible, like through forming co-ops, but also through the prescription possibilities of the province, right? I think it's really worth having DULF come before this committee and give the presentation of, you know, Eris and Jeremy, who are on DULF, have a presentation that you would probably find really helpful on this.
I think
when you can just crack down.
See if we can get the last question, I might have a little one if I can
Just real
sneak it
quick,
in. But go ahead,
I think
Susie.
we need to
Sorry.
eliminate the process that goes through to get an exemption, or to provide, that needs to be streamlined, or or just put a mass exemption out there for because we're in an emergency or something. I think we would have more time if we came to this board or this meeting with an actual presentation in mind around those ideas. But
Okay, go ahead, Susie.
Mine is really sort of clinical, and excuse my ignorance. What is the difference between methadone replacement and methadose? Because I don't know. Okay.
The real quick version is
Yeah.
methadone was generic.
Yes.
Methadose is a brand name prescribed by a pharmaceutical company. The province switched everybody over in 2014.
So it's like going to a generic.
But the methadose doesn't work, doesn't hold people for very long. So we fought for a return to the old stuff. We failed in that fight. We fought for other alternatives. They've come on, but there's been no communication out really. So most doctors, most drug users don't know. Most are still on this, what Jeff calls crappy cough syrup, which is the.
Got it.
Thank you. Do the crap.
Methadose would last for 16.
Got it.
Can I ask hopefully a quick question? What is we've been learning about the toxicity and the response of the drug supply, and you're all speaking about it in a very personal way. What is the kind of, in your view, is it the fentanyl patches? Is it the powder? What is the match to that would be the safe alternative? You already talked about methadone.
The best substitute for street fentanyl is prescription grade fentanyl in whatever formulation we can get it. So if people smoke it, smokable, injectable. On the patches is the best we can be doing right now. It's the closest thing to the street supply is going to get the most people.
That's a good way to put it. It's just the regulated pharmaceutical level, tested, safe, supplies of that drug. And it also needs to be what is the right method, or the right, sorry, I'm losing lots of words here. But whatever is the right, say, what the patient likes to smoke, then they need to have that option. I think Garth has said this, but if they like to inject, then they need to have that option. They what they want, not what the doctor tells them they should be doing.
Thank you all for all that you've taught us today, and the kind of lived experience, but also what you're seeing, and I think it was really impactful for everybody on this committee to hear your voices directly. So I just want to thank you for that. Howard, go ahead.
Do you think you folks could have any kind of influence on actually getting real detoxes out there into the communities? Because not just here, but everywhere. Because you're all over the place, right? So if that's possible to get real detoxes happening and real treatment centers too, is that possible?
Yeah, so what you have before you is a cross-party committee. So we're representing basically every party that's elected in BC, and our job is to hear these real-life needs of what's in the community and give recommendations of what's needed to respond. So we are covering everything, probably likely, not only about what our terms of references are with the direct response of what's needed, but also we have been talking about things like hearing about detox, hearing about treatment centers, and we had a presentation this morning about prevention and what that looks like in terms of mental health services. So this is part of the work that we'll have to do once we hear from as many people as possible. We're kind of in the education phase right now, so we have our ears open. We're hearing from tons of different people.
What about
what's
growing our own poppies here?
Well, it would be part of the deliberation, but I thank you for your thoughts on that. It's been really.
I'd like to invite you all collectively or individually to come to our meetings. We meet every Wednesday except for check day at 2:00 at Vandu, and you would all be most welcome.
Thank you. We really appreciate that.
Crackdown.
That's right. Listen to Crackdown.
We really
Lots
really
of people
appreciate
on the
that.
board
Thank
here
you.
are on the Crackdown podcast, so if you want to hear more.
Yes.
Thank you, and thanks for coming in, and it's been a really great afternoon. Thank you. Yeah, take care.
Thank you all.
Okay, we'll give ourselves a motion to adjourn. We need a motion. Seconded by Joanne. There you go. Okay.